Am I audible and visible? If I'm audible and visible, can I see a thumbs up on the live chat, please? Great to meet you all live after a long time. Yes. So, welcome to the session on image-based questions in biochemistry. Yes, thanks. So, welcome to the session on image-based questions in biochemistry. And what can you expect in this session? In this session, I've chosen all previous year MCQs. Good evening, Vanakkam. Yes, I've chosen all previous year MCQs which are image based, and those questions will be discussed conceptually so that you're able to answer even if there is any twist in those MCQs. Okay, and what is the order in which all these topics will be discussed today? Because in the last LRR session, many gave me inputs or feedback on few topics having not been covered. In today's session, I will be starting with those topics which could not be covered in LRR session. For example, I will be starting with enzymes, minerals, vitamins, clinical biochemistry. After finishing all these topics, we will discuss those topics which were covered in LRR session. So all aspirants, be it NEET PG aspirants or FMGE aspirants or upcoming INI-CET aspirants, do watch both LRR session and image-based questions so that you cover the entire biochemistry in a conceptual manner. Okay, I'm great. Thank you. I'm from Tamil Nadu. Yes. Mic issue. Am I audible, all of you? I think only one person is saying there is a mic issue. One second. Is it clear now? I hope it's clear now. Yes. So can we start with the good. So we'll now start with enzymes. Okay. So in enzymes, what topic can be asked as image-based MCQ? As you all know, it is going to be an MCQ which is based on Lineweaver-Burke plot, right? So these days in most of the exams, they give you a graph and they ask you to find out which type of enzyme inhibition it is. Okay. So the first point that I would like to tell you all is, don't panic whenever you see a graph. Okay, you should be very happy to see a graph because reading a graph is easy. It's going to be very easy if you just see 2 points, right? The first point that you have to observe is what is along x-axis. The second point is what is along y-axis. If you just see that and then try interpreting the graph, it's going to be very easy. Okay, for example, in this graph, can you all tell me what is along x-axis? Yeah, many of you have started answering it right already. So what is along x-axis? Along x-axis, it is 1 by S. And what is along y-axis? It is 1 by V. Okay, that is all you need to check first. Now, the answer for this question is, as you have all been answering, it is competitive inhibition. Okay, but let me tell you this, please don't just memorize the answer. Okay, please don't memorize if it's X, it is competitive inhibition. If it's V, it is non-competitive inhibition. That is not going to help you all the time because even if they change the scale of one axis, it will not look like X, it will not look like V. So you should be able to interpret the graph, whatever the scale they choose for you. Okay, and that's what we are going to do now. Okay, so first let me tell you about inhibition quickly. Just stay with me for the next 5 minutes. At the end of 5 minutes, you will be able to interpret any graph based on Lineweaver-Burke plot. Okay, so I'm going to tell you about enzyme inhibition. As you all know, there are two types of enzyme inhibition. One is reversible inhibition. The other one is irreversible inhibition. For all practical purposes, most of the pharmacological agents that we use belong to reversible inhibition type. Okay. Now, what are the types of reversible inhibitors? Reversible inhibition is of three types. Please listen to this carefully. Reversible inhibition is of three types. The first one is competitive inhibition. The second one is uncompetitive inhibition. The third one is mixed inhibition. And a special type of mixed inhibition is called as non-competitive inhibition. Are you clear about this? You should first know about this classification. We have competitive inhibition, uncompetitive inhibition, and mixed inhibition. A special type of mixed inhibition is called as non-competitive inhibition. Okay. Now, a quick recap on what is Vmax and what is Km. Okay. All that you need to know about Vmax is Vmax is the maximum velocity that is achievable when all the available enzymes, substrate binding sites are saturated with the substrate. Do you understand this? What is Vmax? It's the maximum velocity that is achievable by an enzyme when all the available substrate binding sites of the enzyme have been saturated with the substrate. Okay. Now, what is Km? Km is the substrate concentration at half maximal velocity. All that you need to know is what is Km? It's a substrate concentration at half maximal velocity. Lower the Km, meaning higher is the affinity. Yeah, Km and affinity are inversely proportional. Whenever the enzyme exhibits lower Km, it means the enzyme exhibits higher affinity for the substrate. So these are the facts that you need to know about what is Vmax and what is Km. Okay. Now about Lineweaver-Burke plot or double reciprocal plot. Okay. So before we try to understand about that plot, let me tell you what happens to Km and Vmax in the presence of all these types of enzyme inhibition. Let's start with competitive inhibition. All that you need to know about competitive inhibition is, in the case of competitive inhibition, if you increase the substrate concentration, the competition can be won. Do you understand this? What happens in the case of a competitive inhibition? In the case of a competitive inhibition, a substrate and an inhibitor, they compete with each other to go and bind to the enzyme. So when you increase the substrate concentration, you can overcome the inhibition. The moment you overcome the inhibition, the velocity that is achievable becomes normal. Do you understand this? So in the case of a competitive inhibitor, Vmax is unaltered. How I do make all concepts of biochemistry crystal clear. Please give me suggestion, dear ma'am. So all of you, please watch this session. Yeah, you will understand how to learn biochemistry conceptually. Yeah, at the end, I will tell you, Mohammed. For now, listen to this. So in the case of competitive inhibition, you'll be able to overcome the inhibition. So the maximum velocity that is achievable is unaltered. It is normal, right? But to reach that maximum velocity, you have to increase the substrate concentration. When you increase the substrate concentration, Km will be high. So all of you, please remember what happens in the presence of a competitive inhibitor. In the presence of a competitive inhibitor, Vmax is normal, but Km is high. Clear? Now, uncompetitive inhibition. In the presence of an uncompetitive inhibitor, you cannot overcome the inhibition. If you cannot overcome the inhibition, Vmax will be low. Okay? Not only Vmax is low, Km is also low. So as far as uncompetitive inhibition is concerned, just remember parallel, right? For uncompetitive inhibition, just remember parallel shift. What do I mean by parallel shift? Both Vmax and Km are low. Okay. What happens in the presence of a mixed inhibitor? In the presence of a mixed inhibitor, both the values are altered in the wrong direction. What do I mean by wrong direction? For me to say that an enzyme is good, right? For me to say that an enzyme is good, I should be able to say that the enzyme's Vmax is high and Km is low, right? Only then I'll say this enzyme is good. When will I say an enzyme is good? Only when its Vmax is high and Km is low. But what happens in the presence of a mixed inhibitor? A mixed inhibitor reduces the Vmax and it increases the Km. Do you understand this? It reduces the Bmax and it increases the Km. That is about the effect of a mixed inhibitor. Okay. Now, a special type of mixed inhibitor is non-competitive inhibitor. How are we going to remember about non-competitive inhibitor? Just remember the first two letters. Yeah, first two letters tell you that there is normal Km. In non-competitive inhibition, what is normal? Km is normal. Do you understand this? In non-competitive inhibition, Km is normal, but Vmax is low. Are you clear about this? I hope it's all clear to everybody. Yeah. So quickly, competitive inhibition, you can overcome the inhibition. So Vmax is normal, but Km is high. Uncompetitive inhibition, parallel. Bmax is low, Km is also low. Mixed inhibition, both are mixed. Both the values are in the wrong direction. Bmax is low and Km is high. Non-competitive inhibition, normal Km, NC/NK. Do you understand this? Non-competitive inhibition, it is normal Km, but Bmax is low. Okay. Now, using these facts, how am I going to check the Lineweaver-Burke plot? Okay. So, Lineweaver-Burke plot is otherwise called as double reciprocal plot. Why is it called as double reciprocal plot? Because both along the x-axis and along the y-axis, it is reciprocals. What do you mean by reciprocals? Along x-axis, it is 1 by s. How can you remember this? X and S sound similar. Yes or no? X and S sound similar. So all of you tell me what is along x-axis? Along x-axis, it is 1 by S. Along y-axis, it is 1 by V. How to remember that along y-axis, it is 1 by V? Y and V look similar, right? Y and V look similar. So along y-axis, it is 1 by V. If you draw a graph like this, you will always get a straight line. Do you understand this? You'll always get a straight line. When you extrapolate the straight line touches the y-axis at one point. At what point does it touch the y-axis? It touches the y-axis at 1 by Vmax. Along y-axis, it is 1 by V. So the point at which it touches the y-axis is 1 by Vmax. The point at which it touches the x-axis is minus 1 by Km. Right? The point at which it touches the x-axis is minus 1 by Km. So all of you, please look at this graph. Do you understand this graph now? This is Lineweaver-Burke plot or double reciprocal plot. So all of you focus on this image that is shown here. What is along x-axis? Along x-axis, it is 1 by S. What is along y-axis? Along y-axis, it is 1 by V. You get a straight line. That straight line touches the y-axis at what point? 1 by Vmax. It touches the x-axis at what point? Minus 1 by Km. Okay. So if this is the graph that I get in the absence of an inhibitor, what happens in the presence of a competitive inhibitor? All of you start answering. In the presence of a competitive inhibitor, what happens to Vmax? Please keep the chat box active. What happens to Vmax? Vmax is normal. When Vmax is normal, 1 by Vmax will remain the same. Do you understand this? 1 by Vmax will remain the same. What happens to Km? Km is increased. If Km is increased, 1 by Km is decreased, right? If Km is increased, 1 by Km is decreased. So it will be close to 0. And if you get a line like this, right? If you get a line like this and if you're asked what kind of inhibition is it, then what will be your answer? Your answer should be this is competitive inhibition. Do you understand this? You should say this is competitive inhibition. So for those of you who are watching this session, whenever you see a question on Lineweaver-Burke plot, quickly check the graph. Ascertain that along x-axis it is 1 by S. Be clear that along y-axis it is 1 by V. You will always be shown two lines, right? You'll always be shown two lines. One line tells you in the absence of an inhibitor. The other line tells you what happens in the presence of an inhibitor. Check what happens in the presence of an inhibitor. In the presence of an inhibitor, if Vmax is unaltered, then that is competitive inhibition. Do you understand this? If Vmax is unaltered, it is competitive inhibition. Okay. So now about uncompetitive inhibition. What happens in the presence of an uncompetitive inhibitor? Tell me what happens to Vmax. Vmax is low. What happens to Km? Km is also low. I said parallel shift. If Vmax is low, 1 by Vmax will be high. If Km is low, 1 by Km will be high. Okay. So if you see a line like this, which is shifted parallel, then that is called as uncompetitive inhibition. Whenever you see parallelly shifted lines, please remember it is uncompetitive inhibition. What happens in the presence of a mixed inhibitor? I said a mixed inhibitor reduces the Vmax. So 1 by Vmax will be high. What happens to Km? Km is increased. So 1 by Km will be decreased. So if you see a line like this, right? If you see a line like this, and if you see that the inhibitor is increasing 1 by Vmax and it is decreasing 1 by Km, then what kind of inhibition is it? It is a mixed inhibition. Do you get it? If you see a line like this and if you ask which type of inhibition is it, your answer should be mixed inhibition. The last type is non-competitive inhibition. What did I tell you about non-competitive inhibition? Normal Km. If the Km is normal, 1 by Km will be the same, right? Vmax is low. So 1 by Vmax will be high. And if you see a line like this, do you understand this? If you see a line like this, in the presence of an inhibitor, and if you're asked what kind of inhibition is it, then your answer should be non-competitive inhibition. Are you clear? Then what will be your answer? Your answer will be this is a non-competitive inhibitor. Okay. So this is all about how you find out what type of enzyme inhibition it is. Is that clear? So quickly about the various types of inhibition. All of you please answer along with me. A competitive inhibitor does not alter Vmax, but what happens to Km? Km is increased. Uncompetitive inhibition, parallel shift, both Vmax and Km are low. Mixed inhibition, Vmax is low, Km is high. Non-competitive inhibition, normal Km and Vmax is low. Okay. So try to answer this now, everybody. Identify the type of inhibition exhibited by A. So you know along x-axis it is 1 by S, along y-axis it is 1 by V. You see two lines. One is no inhibitor, the other one is the presence of an inhibitor. Right? The presence of an inhibitor. What has happened to Vmax? Vmax is unaltered. If Vmax is unaltered, what type of inhibition is it? It is competitive inhibition. Okay. So let me see how much of it you have understood, because I'm going to show you one more graph. Right? I'm going to expect you to answer this. So try to answer this, everybody. What type of inhibition does this graph depict? This is uninhibited, this is inhibited. Both have the same Km. Right? What is your answer? If the Km is normal, it is non-competitive inhibition. Very good. Excellent. I'm very happy that all of you are answering it right. Yes, the answer is C, non-competitive inhibition. Good. So are you clear about Lineweaver-Burke plot? I'm very sure that now you will be able to answer any graph which is based on Lineweaver-Burke plot, right? Now, let's start learning about minerals. This is the first question, all of you. A patient presented to the OPD with liver damage. The picture depicts the patient having their eyes examined. Which of the subsequent factors is the cause of this condition? Rudra is answering it as galactose. Rudra, had it been galactose, you would have seen oil drop cataract. Right? Do you see any drop here? You don't see any drop. What do you see instead? It's not galactose, everybody. If it's galactose, you would see a drop in the center. Yeah, this is not oil drop cataract. This is sunflower cataract. And sunflower cataract, yes, is a feature of which condition? Wilson's disease. Wilson's disease is because of copper toxicity. So what is the answer, everybody? The answer for this MCQ is copper. Okay, and let's try to see other images for cataract. Okay, I want you to answer. Please look at this image. Describe this cataract, everybody. What cataract is it? Can you describe this? Anybody? Snowflake cataract. SKF ring is also finding in Wilson's disease. That is another question on KF ring. For now, this is snowflake cataract, which is a feature of juvenile diabetes. Yeah, snowflake cataract is a feature of juvenile diabetes. Very good. Look at this image. Rudra, can you answer now? What do you see here? Do you see an oil drop in the center, right? So this is oil drop cataract, which is a feature of galactosemia. Okay, so that's about copper toxicity, which is a feature of Wilson's disease. But I'm going to use this chance to tell you all about copper metabolism, about Menkes disease and Wilson's disease, because subsequent to this, I have few other MCQs which are image-based questions on all these conditions. Okay, can we start doing that? So copper metabolism, I'm not going to get into the details because it's a rapid revision session. So I'm going to give you just an outline. All of you watch this, you will not regret later. Okay, so copper metabolism. Copper is absorbed from the intestine by ATP7A transporter. Yeah, first it has to be absorbed, right? Absorption is A. So copper is absorbed along the intestine into the portal vein through ATP7A transporter. Through portal vein, it reaches the liver. After it reaches the liver, ATP7B transporter has two functions. So what are the two functions? B, bifunction. Do you understand this? B, bifunction. So what are the two functions of ATP7B? B for bile. So one function is it secretes copper back into bile so that copper gets excreted in the feces. Because we don't want to be storing excess copper, because copper toxicity is something which is dangerous. So 7B is bifunctional. One is B, it secretes copper into bile. The other one is it secretes it into the blood. B for bile and blood. What happens once it gets into the blood? In the blood, copper gets into apoceruloplasmin, converting apoceruloplasmin to ceruloplasmin. So what are the two effects of it getting incorporated into ceruloplasmin? One is ceruloplasmin is getting stabilized. Why do you have to stabilize ceruloplasmin? Because ceruloplasmin is a ferrooxidase which protects the body from iron toxicity. Do you understand this? Ceruloplasmin is ferrooxidase which protects the body from the oxidative stress that can potentially be caused by iron. So it has to be stabilized, and that stabilization is done by copper getting incorporated into ceruloplasmin. That is one effect. The other effect is this way copper is getting protected from getting excreted in urine. If copper stays as copper, it gets excreted in urine. Now that copper has got incorporated into ceruloplasmin, it will not get excreted in urine. So as ceruloplasmin, it goes to tissues. What happens in tissues? In tissues, copper will get incorporated into all enzymes like lysyl oxidase. I started liking biochemistry. Please guide how do I revise or go for biochemistry for INI-CET November. The Jumble Studio. I don't know why you've named yourself as Jumble Studio, but it sounds interesting. So stay with me for the next 1.5 hours. At the end of the session, I will tell you how to revise biochemistry quickly. All right. For now, I want you to focus on this session because every minute counts. And in this session particularly, it's a high yielding session. Every minute counts. There is a very high probability of questions being asked based on this session. Okay, so listen to this. So it gets incorporated into lysyl oxidase, superoxide dismutase, that is done by ceruloplasmin. Are you clear about this? This is an overview of copper metabolism. Now, what is Menkes disease? right? Menkes disease is because of a mutation of ATP7A. So you're going to tell me what will happen when ATP7A is not working properly. Absorption of copper does not happen. When copper is not absorbed, what will you find out? You will find out copper deficiency. When there is copper deficiency, enzymes like lysyl oxidase will be inactive. When lysyl oxidase is inactive, collagen cross linkage formation, collagen maturation cannot happen. When there is no collagen cross linkage formation or collagen maturation defect, that causes kinky hair, that causes fractures and hypotonia, right? Probably like my hair. Okay. So kinky hair, fractures and hypotonia are the features of Menkes disease. Okay. So are you clear about Menkes disease? All of you tell me. Yeah, tell me Menkes disease is because of a defect of ATP7A. Copper absorption defect, copper deficiency, lysyl oxidase is defective. Without lysyl oxidase, what do you expect? Collagen maturation does not happen, and that causes kinky hair, fractures and hypotonia. Okay. Now let's learn about Wilson's disease. Wilson's disease is because of the defect of which protein, all of you? ATP7B. So tell me, what are the effects? Now you know the effect, right? When ATP7B is mutated, what will not happen? Copper will not get excreted into bile, right? Copper will not get incorporated into ceruloplasmin. So what are the effects? When copper is not getting secreted into bile, copper gets accumulated in the body, causing copper toxicity. That is why Wilson's disease is copper toxicity. When copper accumulates in the liver, that causes liver damage. When copper accumulates in the lenticular nucleus is damaged. Hence the name hepatolenticular degeneration. So hepatolenticular degeneration is because of copper toxicity that damages liver and damages lenticular nucleus. Now tell me what will happen when copper is not incorporated into ceruloplasmin. Ceruloplasmin is not stabilized, right? Ceruloplasmin is damaged quickly. That causes low ceruloplasmin levels. So all of you, those who are watching this session, low ceruloplasmin is not the cause of Wilson's. Low ceruloplasmin is the effect of Wilson's. Do you understand this? The other effect is when copper is not getting incorporated into ceruloplasmin, copper, I said, will get excreted in urine. So serum copper level will be low. Do you understand the paradox here? All of you watch this carefully. What is the paradox that you observe here? Wilson's disease is a copper toxicity disorder, but with low serum copper. Are you clear? It's a copper toxicity disorder with low serum copper because copper is excreted in urine. So urinary copper will be high. Okay. So about diagnostic investigation of Wilson's disease. In Wilson's disease, the first diagnostic investigation that you can ask for is ceruloplasmin levels, which will be low. So ceruloplasmin level will be less than 0.2 grams per liter. All of you remember the value? Low ceruloplasmin less than 0.2 gram per liter in the serum. Okay. Second investigation is you can ask for urinary copper. Urinary copper, 24 hours urinary copper if it's more than 100 microgram. Yeah, if 24 hours urinary copper is more than 100 microgram, then that is Wilson's disease. Third and definitive investigation. What is the definitive investigation for Wilson's disease? Liver biopsy and checking the copper content in liver. If the copper content in liver is more than 250 microgram per gram of tissue. Yeah, so when liver copper is more than 250 microgram per gram of tissue, that is the definitive diagnostic investigation for Wilson's disease. Okay, so these are the investigations that you can ask for Wilson's disease. I'm going to tell you only about the investigations of Wilson's disease. What did I tell you? The first one is serum ceruloplasmin level less than 0.2 gram per liter. Urinary copper more than 100 microgram per 24 hours. Liver copper more than 250 microgram per gram of tissue, And which is the definitive diagnosis? This is the definitive diagnosis. Are you clear? Yeah, some of you are shocked to see me. I can see that. Yeah, I'll tell you about that later probably when you're bored. Yes. I thought I should stop straightening because I know straightening is full of chemicals and this is my natural hair. Okay. Does that answer your question? Yeah. A patient presented to the OPD with liver damage. The picture depicts the patient. Thanks all of you. So what is answer? The answer is copper. Deficiency of copper, which is necessary for lysyl. Thanks all of you. So deficiency of copper, which is necessary for lysyl oxidase is seen in. What is answer? Menkes disease. Yes. Scurvy, I saw one of you answering it as scurvy. Scurvy is vitamin C deficiency. Copper deficiency is Menkes disease. Try to answer this. Now you know the answer, right? It's a NEET 2024 MCQ. What is shown in the image? The image shows Kayser-Fleischer ring, which is brownish or greenish ring that is seen around the iris, caused by the accumulation of copper in the Descemet's membrane, right? Kayser-Fleischer ring. The person presents with jaundice, fatigue, muscle stiffness, tremors because lenticular nucleus is damaged, KF ring. All these point towards a diagnosis of Wilson's disease. They're asking you what is the definitive diagnosis. Yes, excellent everybody. The definitive diagnosis is hepatic parenchymal copper concentration. If it's more than, what is the value I told you? 250 microgram per gram of dry tissue. "14-month-old child presented with erythematous scaly pustula lesions. Can you see in the perioral region and in the anal region, right? It is acrodermatitis and diarrhea. Acrodermatitis enteropathica, right? The probable mineral deficiency is excellent. Acrodermatitis enteropathica is because of zinc malabsorption, right? Because of a defect of zinc transporter. So the answer here is zinc. Good. SLC 34. Okay, answer is zinc. One more fact about zinc is whenever you see poor wound healing, whenever you see poor wound healing, you should think of 3 micronutrients, right? One is copper, second is vitamin C, third is zinc, right? Poor wound healing is a feature of copper deficiency, vitamin C deficiency, and zinc deficiency. Can we start discussing vitamins now? How many of you want to learn about vitamins? Yeah, vitamin is a very popular topic, right? They often ask you MCQs on vitamins, principally because you will be able to answer vitamins only when you know the entire metabolism, right? Vitamins play a significant role in metabolism. So instead of them checking whether you've learned about metabolism, if they ask you about vitamins, they will be able to find that out. That is why they ask you questions on vitamins. Let's start discussing. So everything is given in the image. That is why I would always say this to all students. When you see an image-based question, please be happy about it, right? Many a times clues will be there in the image, okay? They've shown you which is white line of Frankel. They've shown you Pelkin's fracture. They've shown you Wimberger's ring sign, right? All these are features, radiological features of what? Scurvy, right? And additionally, they've given you bleeding gums, right? Bleeding gums is scurvy. Apart from bleeding gums, you should know that there can be bone manifestations, which can be seen as white line of Frankel. It can be seen as Pelkin's fracture. It can be seen as Wimberger's ring sign. So what is answer? Scurvy is because of vitamin C deficiency. I will help you understand this more. Okay. So vitamin C. What is vitamin C necessary for? Vitamin C acts as a coenzyme for prolyl hydroxylase and lysyl hydroxylase. Both prolyl hydroxylase and lysyl hydroxylase are necessary for collagen cross-linkage formation and for collagen maturation. Apart from this, vitamin C is also necessary as a reducing substance which can reduce ferric to ferrous, and it helps in iron absorption. That is why in vitamin C deficiency, you see anemia. Do you understand this? In vitamin C deficiency, you see anemia. You also see collagen maturation defects. What will happen whenever there is collagen maturation defects? The subendothelial connective tissue becomes weaker. When the subendothelial connective tissue is weaker, there will be multiple sites wherein bleeding is observed. And that is why you see bleeding gums. Apart from that, what do you see in bones, right? What is white line of Frankel? I want you to know that scurvy is a defect of metaphysis. Why is it a defect of metaphysis? Because that is where you see the growth plate. What should happen in growth plate? In growth plate, ossification should happen. Can anybody tell me what is ossification? Ossification involves both calcification as well as collagen deposition. What happens in scurvy? In scurvy, there is no defect in calcium deposition. So, continuously mineralization of the growth plate happens. But what is not happening? Collagen deposition does not happen. That mineralized metaphysis which has failed to ossify. Do you understand this? That mineralized metaphysis that has failed to ossify is responsible for the dark line that you see. That is called as white line of Frankel. If there is no collagen deposition, it means it's weaker. If metaphysis is weaker, many a times that metaphysis undergoes breakage, and that causes Pelkin's fracture. Repeated metaphysis breakage will cause a spur, right? Will cause a spur that is called as Pelkin's fracture. So please remember, scurvy is a defect of which part of the bone? Metaphysis, wherein you have the growth plate, wherein calcification happens without collagen deposition. That calcified edge causes white line of Frankel, that causes Pelkin's fracture. And in epiphysis, right? In epiphysis also you will see a bright line. Right, you see a dense line which looks like a ring, and that is called as Wimberger's ring. Okay, so all these point towards what? All these point towards scurvy, which is caused by vitamin C deficiency. Okay. I know all of you know the answer for this question, right? What is the answer? What do you see here? Symptoms of dermatitis. It is Castle's necklace. The moment you see Castle's necklace, which is dermatitis, dementia, right? Dermatitis, dementia, and diarrhea. 3 Ds of pellagra caused by vitamin B3 deficiency. All of you remember 3 Ds of pellagra. What are the 3 Ds? Diarrhea, dermatitis, dementia. Caused by vitamin B3 deficiency or niacin deficiency. If you know this, do you think that is enough? That is not enough, right? You need to know all about niacin. You need to know what are the causes of niacin deficiency, and that's what I'm going to tell you about now. Okay, so for this, you will have to know few facts about niacin. Is this for FMGE or NEET PG? Vishwanath Vishwa, when I started the session, I told you both NEET PG aspirants and FMGE aspirants will get benefited if you watch the session. Not just you both. Even INI-CET aspirants will get benefited because ultimately the concepts that you need to know is the same. And here I've included both previous year NEET PG and FMGE MCQs. Got it? Yes. Not just LRR, watch image-based question session also, Syed. So what was, yeah. So niacin, few facts about niacin. Niacin is one micronutrient which can be synthesized by your body, right? It's an essential micronutrient that can be synthesized by your body from tryptophan. Please remember, niacin is synthesized from tryptophan. You must have learned that 60 milligram of tryptophan is equivalent to 1 milligram of niacin. Second fact, tryptophan is necessary for synthesizing two substances. One is serotonin. From tryptophan, you can synthesize serotonin because what is serotonin? 5-hydroxytryptamine. Okay. Second is from tryptophan, you can also synthesize niacin. For you to convert tryptophan to niacin, there are two enzymes which are necessary. There are many enzymes, but there are two clinically significant enzymes that you should remember. One is kynurenase. Why is kynurenase important? Because it is dependent on B6. Kynurenase is dependent on B6. Another enzyme that you should remember is quinolinate phosphoribosyl transferase. Why should you remember about quinolinate phosphoribosyl transferase here? Because it is inhibited by leucine. This enzyme is inhibited by leucine. So all of you look at this slide. This slide has many important clinical facts because based on this, you're going to tell me the causes of pellagra. Okay. So what are the facts that I told you? Niacin is synthesized from tryptophan, but tryptophan is also necessary for synthesizing serotonin. To convert tryptophan to niacin, we need two enzymes. One is kynurenase, the other one is quinolinate phosphoribosyl transferase. Kynurenase is dependent on B6. Quinolinate phosphoribosyl transferase is inhibited by leucine. So based on this, can you all tell me what are the causes of pellagra? Obviously, the first cause of pellagra would be dietary deficiency of niacin. Right? One is dietary deficiency of niacin. Second is dietary deficiency of tryptophan. If there is no tryptophan, niacin cannot be synthesized. This happens in maize-based diet. Bioavailability of tryptophan from maize is low. So maize-based diet can cause pellagra. That is second cause. Third, even if the diet has got tryptophan, what if there is tryptophan malabsorption? Right? That is called as Hartnupp's disease. Tryptophan malabsorption is called as Hartnupp's disease. So what will you expect in Hartnupp's disease? It's a defect of a transporter. Right? It's a defect of a transporter which is responsible for tryptophan absorption along the intestine and tryptophan reabsorption along the proximal convoluted tubule. When both these transporters are defective, what do you expect? Tryptophan is not absorbed, niacin is not synthesized. That causes 3 Ds of pellagra. When tryptophan is not reabsorbed along the proximal convoluted tubule, tryptophan will be found in urine. Right? So what will you see? You will see aminoaciduria. When tryptophan is found in urine, you will see aminoaciduria. So all of you listen to this. Whenever they say that a child presents with 3 Ds of pellagra with aminoaciduria, and they say that it sounds like it's a hereditary condition, then you should think of Hartnupp's disease. Do you understand this? 3 Ds of pellagra with aminoaciduria is Hartnupp's disease. Now, there is tryptophan in the diet. Tryptophan is also absorbed. And in the body, what will happen when tryptophan is used for serotonin synthesis? Then tryptophan will not be available for niacin synthesis. When will tryptophan be used for serotonin synthesis? In carcinoid syndrome. So, carcinoid syndrome is another cause of pellagra. Okay, everything is good. Tryptophan has entered into niacin synthetic pathway. What if there is B6 deficiency? In the absence of B6, kynurenase is inactive. So tryptophan cannot be converted to niacin. That also causes pellagra. So all of you, those who are watching the session, don't you find this to be interesting? All along you have been learning that pellagra is caused by niacin deficiency. Today you have learned that pellagra is also caused by B6 deficiency because which enzyme is dependent on B6? Kynurenase is dependent on B6. Everything is good. Tryptophan has entered into niacin synthetic pathway. What if quinolinate phosphoribosyl transferase is inhibited by leucine? Right? That is called as leucine pellagra. Right? So leucine pellagra happens whenever a person is on a sorghum based diet. Okay, sorghum is a staple diet among few farmers. Okay, this sorghum is rich in leucine. Though leucine is an amino acid, it inhibits quinolinate phosphoribosyltransferase transferase and that causes pellagra. That's called as leucine pellagra. So these are the causes of pellagra. Are you clear? So can you tell me quickly the causes of pellagra? Niacin deficiency, which we all know. Tryptophan deficiency, which is maize-based diet. Tryptophan malabsorption or Hartnupp's disease. Carcinoid syndrome when it is used for serotonin synthesis. B6 deficiency, and then leucine pellagra, which is sorghum-based diet. Okay, along with this, I'm going to tell you one other high yield fact. All of you watch this. One more high yield fact is based on this slide. Okay, what happens whenever there is B6 deficiency? Whenever there is B6 deficiency, which enzyme is inactive? Kynurenase is inactive. When kynurenase is inactive, the precursor kynuren gets converted to xanthurenic acid. When kynurenase is inactive, the precursor kynuren gets converted to xanthurenic acid. So all of you listen to this. Whenever you suspect B6 deficiency, please look at the slide here. Whenever you suspect B6 deficiency, what is the last letter for 6X? So what will you estimate in urine? You should estimate xanthurenic acid level in urine. When will you estimate xanthurenic acid level? After tryptophan load. After X, the alphabet is Y. Y stands here for tryptophan. Are you clear? So tell me all of you, what will you do whenever you suspect B6 deficiency? Whenever you suspect B6 deficiency, you estimate xanthurenic acid level after tryptophan load. Okay. So that's about niacin and that's about B6. Okay. So answer this question. One more. So we know this answer, right? So which micronutrient deficiency is most likely responsible here? It is niacin. So NEET PG 2024 MCQ. A farmer is on a maize-based diet. The moment you see maize-based diet, please remember maize tryptophan availability is low. Without tryptophan, there will be 3 Ds of pellagra. So the person has developed skin rashes on face, neck and hand. Which of the following should be given? Excellent. Niacin has to be given. Do you all remember this MCQ? What is the source of vitamin B1 or thiamine here? They gave you a plate. They asked you to find out which is the source. What is the right answer, everybody? Good, Tanya. Good, Rafa. Good, Akanksha. Yes. So the answer is rice. Answer is A. Okay. So why or how did I exclude other choices? What is B and what is C? B looks like paneer. C looks like curd or yogurt, right? Paneer and yogurt are dairy products. What are the vitamins that you can see in dairy products? Dairy products are always rich in B12. They are rich in B2, obviously in vitamin D, right? Dairy products are rich in B12, B2 and D. They are not going to be rich in thiamine because thiamine is seen in whole grains. Do you understand this? Thiamine is rich in whole grains. And what made me exclude? Yes, what made me exclude D? What is D? It looks like a fruit and vegetable salad, right? Fruits and vegetables are rich in vitamin C, right? Fruits and vegetables are rich in vitamin C. Cucumber is rich in vitamin K. Cucumber, vitamin K. Carrot is rich in vitamin A. They don't have thiamine. So what is the right answer? The right answer is parboiled rice, right? The answer is parboiled rice because polishing rice will get rid of the allurin layer which is rich in thiamine. And if a person continuously consumes polished rice, that can be thiamine deficiency. Okay. Now based on this, how many of you want to learn all about thiamine? Thiamine is a frequently asked topic, right? So I'm going to tell you all about thiamine now. What are the thiamine dependent enzymes? There are 4 thiamine dependent enzymes. The first enzyme is pyruvate dehydrogenase. Along with pyruvate dehydrogenase, always learn alpha ketoglutarate dehydrogenase. Both are very similar. Okay, pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase. Third one is branch chain keto acid dehydrogenase. Have you learnt about branch chain keto acid dehydrogenase before? Defect of branch chain keto acid dehydrogenase causes maple syrup urine disease. Okay, so the third one is branch chain keto acid dehydrogenase. The fourth one is trans ketolase. So all of you tell me, what are the thymine dependent enzymes? Pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, nobody should forget this, branch chain keto acid dehydrogenase and trans ketolase. Based on this, we are going to learn what will happen whenever there is thymine deficiency. For you to understand thymine deficiency manifestations, let's quickly recall what we know about PDH complex. So tell me, what is that you know about PDH complex? PDH complex converts pyruvate into acetyl-CoA so that acetyl-CoA can get into citric acid cycle, can come out as carbon dioxide. From where do you get glucose? You get glucose from where do you get pyruvate? You get pyruvate from glucose. Okay. So if you ask me, what exactly is the function of PDH complex? I would say PDH complex is involved in aerobic utilization of glucose. Do you all understand this? What is PDH complex involved in? It is involved in aerobic utilization of glucose as a fuel. Okay. That is why what happens whenever there is thymine deficiency? This PDH complex is dependent on thymine. So whenever there is thymine deficiency, PDH complex is inactive. So aerobic utilization of glucose cannot happen. Which cell in your body uses glucose aerobically? All of you remember, neurons. Neurons use glucose aerobically. RBCs use glucose anaerobically. Neurons use glucose aerobically. So whenever there is thymine deficiency, when aerobic utilization of glucose does not happen, neurons get affected, and that is why you see dry beriberi. Do you all understand this? Have you all learned that in dry beriberi nerves get affected? Do you all understand why? Yeah. So I always say this in every session of mine. Okay. If somebody tells you that biochemistry is a preclinical subject, right? What are you supposed to say? You're supposed to vehemently oppose it, right? Biochemistry is not just about cycles and pathways. Just because we have been learning only cycles and pathways, it does not mean biochemistry is just about cycles and pathways. Biochemistry is all about applied biochemistry. You will be able to understand so many clinical aspects if you have a strong understanding of biochemistry. Okay. And my aim, right, wherever I go, whenever I teach biochemistry, my aim is to help students understand the clinical side of biochemistry. And there is no advantage if you just memorize that thymine deficiency causes dry beriberi. If you just memorize that dry beriberi is neurological manifestations, you should know why. Only when you know why, when you see it, you will be able to identify it. Do you all understand this? So why should thymine deficiency? Yeah, welcome to real world. Excellent. So tell me, why should thymine deficiency cause dry beriberi? When there is thymine deficiency, PDH complex is inactive. Without PDH complex, aerobic utilization of glucose cannot happen. Neurons get affected, and that causes dry beriberi. Okay. And apart from this, people laugh at you. Yeah. So you can laugh at them back because they have not understood what exactly biochemistry is, and they are missing out on a major part of medicine. Okay, so you can laugh at them back. So apart from this, I want you to also remember that pyruvate has another fate. If pyruvate is not converted to acetyl-CoA, pyruvate gets converted to lactate. Don't you know that if pyruvate is not converted to acetyl-CoA, pyruvate gets converted to lactate. So in thiamine deficiency, when PDH complex is inactive, all pyruvate get converted to lactate and that causes lactic acidosis. In thiamine deficiency, what do you observe? You observe lactic acidosis. And this lactic acidosis is responsible for wet beriberi. Have you all learned that in wet beriberi, cardiovascular system is involved? So why should cardiovascular system be involved whenever there is lactic acidosis? Because lactic acid is a vasodilator. To be very specific, it's an arteriolar dilator and it causes venoconstriction. So what does lactic acid cause? Lactic acid causes arteriolar dilatation and venoconstriction. When there is arteriolar dilatation, that causes hypotension and tachycardia. On one hand, arterioles are getting dilated. On the other hand, veins are getting constricted. So in the capillary, hydrostatic pressure increases. Whenever the hydrostatic pressure in capillary increases, that causes edema. So what is one of the features of wet beriberi? Wet beriberi is characterized by peripheral pitting edema. Why do you see peripheral pitting edema? Because there is arteriolar dilatation and venoconstriction. So capillaries hydrostatic pressure increases, that oozes into interstitium, causes pitting pedal edema, and sometimes it also presents with cardiac failure. Okay, all together will be called as wet beriberi. Okay, so tell me, what do you expect in thiamine deficiency? In thiamine deficiency, you observe dry beriberi, you observe wet beriberi, dry beriberi with neurological manifestations, wet beriberi with hypotension, tachycardia, peripheral edema, and cardiac failure. That's because of lactic acidosis. And because branch chain keto acid dehydrogenase is dependent on thiamine, whenever you make a diagnosis of maple syrup urine disease, you start supplementing thiamine. Maple syrup urine disease responds to which vitamin administration? Thiamine administration. And because trans ketolase is dependent on thiamine, whenever you suspect thiamine deficiency, because trans ketolase is dependent on thiamine, whenever you suspect thiamine deficiency, you should ask for RBC trans ketolase activity. You should ask for RBC trans ketolase activity. So have you already learnt about 2 vitamin deficiency diagnostic tests? Can you all repeat this? Whenever you suspect B6 deficiency, what will you estimate? You will estimate xanthurenic acid level after tryptophan load. Okay. Whenever you suspect thiamine deficiency, you ask for RBC trans ketolase activity. Few more facts about thiamine, right? Thiamine is a sulfur containing vitamin. Do you understand this? Thiamine is a sulfur containing vitamin. There are 2 sulfur containing vitamins. One is biotin, the other one is thiamine. Second fact is, as I told you, whole grains can act as a source of thiamine. Once you polish rice, the allurin layer is removed and that causes thiamine deficiency. That's all about thiamine. Okay. Now try to answer this. A family consuming predominantly of polished rice presents with pitting pedal edema. Okay. So pitting pedal edema, polished rice. What will you suspect? Thiamine deficiency. Match the vitamin deficiency with the investigation used to detect the deficiency. What is your answer? Your answer is thiamine deficiency. With what investigation? Trans ketolase activity. Yes, very good. It is wet beriberi. Good. So can we learn about all vitamin deficiency diagnostic tests? Yeah, vitamin deficiency diagnostic test. All of you watch this. I want you to observe this and I want you to memorize it because you will be given this annotated PDF in which all facts are provided. Okay, so let's start with B1. Can you all start answering? B1. What will you measure? you will measure RBC transketolase activity. Next is B2. What is B2, everybody? B2 is riboflavin. Okay. For ribbon, remember glue. Right? For ribbon, you remember glue. So riboflavin deficiency, what will you estimate? RBC glutathione reductase activity. For riboflavin deficiency, very good SS. It is RBC glutathione reductase activity. Second one is B6. Just now I told you B6, what will you estimate? Xanthurenic acid level after what load? After tryptophan load. B6 is xanthurenic acid level after tryptophan load. After B6, let's learn about B9 or folate. If you suspect folate deficiency, F for F. Folate deficiency, what will you estimate, all of you? FIGLU levels. After what load? FMGE are over after histidine load. Okay. After B9, B12. Whenever you suspect B12 deficiency, what will you estimate? You should estimate methylmalonic acid level in urine. Yeah, you should estimate methylmalonic acid level in urine after overnight fasting. Do you understand this? After overnight fasting. So look at this table and repeat it along with me. Tell me, when you suspect thiamine deficiency, what will you measure? RBC, transketolase activity. B2, riboflavin, ribbon and glue. RBC, glutathione reductase activity. B6X, xanthurenic acid after tryptophan load. Folate, F for F, FIGLU levels after histidine load. B12, methylmalonic acid levels after overnight fasting. Okay. So try answering this. A vegetarian patient presents with anemia and hypersegmented neutrophil. Do you see that here? Hypersegmented neutrophil. More than 5 lobes. If you see more than 5 lobes in neutrophil, that is hypersegmented neutrophil. So the most probable causes, hypersegmented neutrophil meaning macrocytic anemia. If it's macrocytic anemia, you can exclude iron deficiency anemia and anemia of chronic disease because both will present themselves as microcytic hypochromic anemia. Between B12 and folate deficiency, let me exclude folate deficiency because of the dietary history. Right? Folate is seen in green leafy vegetable. A vegetarian should not present with folate deficiency but will present with B12 deficiency because B12, most of the sources are non-vegetarian. Right? So what is the answer here? The answer here is B12 deficiency. So can we learn all about B12 now quickly? When I say all about B12, I'm not going to get into the details, just high yield facts that you need to know about B12. Okay. So what are the two coenzyme forms of B12? The two coenzyme forms of B12 are, number one is adenosyl B12. Let's start with A, adenosyl B12. The other one is methyl B12. Please memorize it, adenosyl B12 and methyl B12. Adenosyl B12 acts as a coenzyme for only one enzyme, which is methylmalonyl-CoA mutase. Now, what is the role of methylmalonyl-CoA mutase? Methylmalonyl-CoA mutase converts methylmalonyl-CoA to succinyl-CoA. From where do we get methylmalonyl-CoA? You get methylmalonyl-CoA from propionyl-CoA. From where do you get propionyl-CoA? You get propionyl-CoA from odd chain fatty acid oxidation. Do you understand this? So let me repeat this. Adenosyl B12 is necessary as a coenzyme for methylmalonyl-CoA mutase, triple M. What is the role of methylmalonyl-CoA mutase? It converts methylmalonyl-CoA to succinyl-CoA. From where do you get methylmalonyl-CoA? Propionyl-CoA. From where do you get propionyl-CoA? From odd chain fatty acid oxidation. This is why what happens whenever there is B12 deficiency, Whenever there is B12 deficiency, methylmalonyl-CoA mutase is inactive. That causes methylmalonyl-CoA to accumulate. This is why I told you, whenever you suspect B12 deficiency, you should estimate methylmalonic acid levels after overnight fasting. Not just this, when methylmalonic acid accumulates, it gets incorporated into myelin, and that causes demyelination. This demyelination is responsible for the neurological manifestations of B12 deficiency. Do you all understand this? Don't you all know this already? You all know that B12 deficiency presents with neurological manifestations, because whenever there is B12 deficiency, they first present with peripheral sensory neuropathy. They present with pins and needle sensation in the periphery that progresses to subacute combined degeneration. So why should B12 deficiency cause neurological manifestations? It is because of methylmalonic aciduria. It's because methylmalonic acid interferes with myelination. Okay. Now about methyl B12. Methyl B12 acts as a coenzyme for only one enzyme, and that enzyme is methionine synthase. Methyl B12 acts as a coenzyme for methionine synthase. What is the function of methionine synthase? Methionine synthase helps in the conversion of homocysteine to methionine. Okay. And another fact about methyl B12 is methyl B12 gets its methyl group from methyl tetrahydrofolate. Do you understand this? Methyl B12 gets its methyl group from methyl tetrahydrofolate. That is why what happens whenever there is B12 deficiency? Whenever there is B12 deficiency, there is no methyl B12, there is no methionine synthase. That causes homocysteinuria. So B12 deficiency is one of the causes of homocysteinuria. This has got a clinical significance. All of you listen to me. Suppose you see a young patient presenting with triple vessel disease, right? A young patient is presenting with triple vessel disease. You have performed bypass graft for that patient, right? And after that, you start analyzing the causes. When you start analyzing causes, you would estimate lipid profile, you would estimate coagulation profile. But along with that, also estimate homocysteine, because homocysteinuria causes accelerated atherosclerosis and accelerated thrombosis. Suppose you see that in your patient, homocysteine levels are high, right? Irrespective of the cause, you can give B12, because when you give B12, homocysteine becomes methionine. Do you all understand this? And that is why B12 deficiency causes homocysteinuria. Another effect of B12 deficiency is when there is no B12 to which tetrahydrofolate can donate its methyl group, all tetrahydrofolate will be trapped as methyl tetrahydrofolate. Do you all understand this? In your body, any tetrahydrofolate that is available becomes methyl tetrahydrofolate. Then this methyl group has to be donated to B12. If there is no B12, methyl tetrahydrofolate cannot donate its methyl group. So all tetrahydrofolate will be trapped as methyl tetrahydrofolate, and that is called as methyl folate trap. So tell me, what is methyl folate trap? What is the cause of methyl folate trap, everybody? The cause of methyl folate trap is B12 deficiency. What is the effect of methyl folate trap? Whenever there is B12 deficiency, there will be a functional deficiency of tetrahydrofolate as well. Why? Because all tetrahydrofolate are trapped as methyl tetrahydrofolate. Okay. Because of the low activity of which B12 dependent enzyme? Because of low activity of methionine synthase. Okay. And this low folate causes macrocytic anemia. We already know that, right? Folate deficiency causes macrocytic anemia. That is why B12 deficiency causes macrocytic anemia. Do you get it? Folate deficiency directly causes macrocytic anemia. B12 deficiency causes macrocytic anemia because in B12 deficiency, there is a functional deficiency of tetrahydrofolate. Okay. So can you tell me what are the manifestations of B12 deficiency? Can you all answer this, everybody? B12 deficiency causes methylmalonic aciduria. It causes neurological manifestations, right? It causes homocystinuria. It causes methylfolate trap. This methylfolate trap is the reason for macrocytic anemia. Are you clear? Can you all repeat this? B12 deficiency causes methylmalonic aciduria and neurological manifestations. It causes homocystinuria, methylfolate trap, and macrocytic anemia. Okay. Now, it's essential that you summarize and find out causes of macrocytic anemia. You know, macrocytic anemia can be either because of B12 deficiency or because of folate deficiency. So if your patient presents with macrocytic anemia, how will you find out whether it is B12 deficiency or is it folate deficiency? Can you all start answering? Starting from, I will check the dietary history. Right? What will I see in dietary history for B12 deficiency? Strict vegetarian diet. Veganism is a cause of B12 deficiency. What will be the cause of folate deficiency? Strict non-vegetarian diet. If a person does not take green leafy vegetables, then that can be folate deficiency. Second difference, check for neurological manifestations, right? If you see neurological manifestations, it's B12 deficiency. No neurological manifestations, only macrocytic anemia, it is folate deficiency. Finally, diagnostic investigations. Finally, you're going to confirm based on an evidence, right? What is the evidence? For B12 deficiency, you will see elevated methylmalonic acid level after overnight fasting, and you will see elevated homocysteine. Whereas folate deficiency, what will be elevated? FIGLU levels will be elevated after histidine load. In folate deficiency, you will see that FIGLU levels are elevated after histidine load. So this is how you can differentiate B12 and folate deficiency. Are you all clear? Yeah. So do you all still think that biochemistry is just about cycles and pathways? No, right? How much of diagnosis is dependent on biochemical investigations? Can you see that here? Right? So B12 deficiency, dietary history is veganism. Folate deficiency, dietary history, strict non-vegetarian diet. B12 deficiency presents with neurological manifestations. In B12 deficiency, there is elevation of methylmalonic acid and elevation of homocysteine. Whereas in folate deficiency, there is elevation of FIGLU. Okay. If a pregnant woman with hypersegmented neutrophil, should we choose folate deficiency over B12? Without an investigation, please don't start folate. Okay. Without an investigation in macrocytic anemia, be it pregnancy or no pregnancy, don't just start folate. Because if it's B12 deficiency and if you start folate, then neurological manifestations will be aggravated. And that is why you should always check B12 deficiency investigations and then you start with preferably both B12 and folate. Do you all understand this, Gayatri? That's a very good question that you asked. Okay, so if there is B12, if there is macrocytic anemia, don't just start folate. If you start folate supplementation in B12 deficiency, neurological manifestations will be aggravated. Yes. Patient underwent gastrectomy and presents with anemia. After gastrectomy, anemia with hypersegmented neutrophils, right? Which of the following deficiency may occur? B12, right? What is answer? It is B12. Yes, because following gastrectomy, what will be deficient? Intrinsic factor will be deficient. Without intrinsic factor, what cannot be absorbed? B12 cannot be absorbed. Okay, so can we learn about B12 absorption? I'm not going to get into the details again. We are going to discuss only high yield facts. We are going to discuss only about applied aspects. Okay, so B12 absorption factors. So the first factor B12 is dependent on is intrinsic factor. Okay, I'm not going to tell you about R binder. Not many clinical conditions are related to it. Let's skip R binder. Let's go to intrinsic factor. The first factor is intrinsic factor secreted by gastric parietal cells. Second factor is pancreatic enzymes. Why pancreatic enzymes? Because all B12 sources are non-vegetarian. So all B12 forms will be attached to proteins. Only when you have a pancreatic enzyme which digests the protein, B12 can be absorbed. So B12 absorption is dependent on pancreatic enzymes. Third is, now B12 has reached the terminal ileum. It gets absorbed in terminal ileum after binding to cobalamin receptors present in the terminal ileum. So the third factor is cobalamin receptors which are present in the terminal ileum. Even if everything is fine, there is intrinsic factor, there is pancreatic enzyme, the terminal ileum is good. Even then, if colon is loaded with microorganisms, microorganisms utilize B12, causing B12 malabsorption. So these are the factors. Accordingly, can anybody tell me what are the causes of B12 malabsorption, everybody? What are the causes of B12 malabsorption? Intrinsic factor deficiency. Right? As which happens in autoimmune gastritis, type A or autoimmune gastritis or gastrectomy. Okay. Then pancreatic enzyme deficiency. Whenever there is pancreatic insufficiency of any cause, that will cause B12 malabsorption. Then terminal ileal disease. Crohn's disease, right? Terminal ileal disease or Crohn's disease is a cause of B12 malabsorption. Everything is good when there is a blind loop syndrome, right? Blind loop syndrome and the colon is loaded with microorganisms, all B12 will get utilized and that will also cause B12 malabsorption. So all of you tell me what are the causes of B12 malabsorption? Autoimmune gastritis or gastrectomy, pancreatic insufficiency, ileal disease, example Crohn's disease or blind loop syndrome. Okay. I hope you're all enjoying learning biochemistry now. Can I see a thumbs up if you enjoy biochemistry? Yeah. Nobody enjoys? Good, Gayatri. Thanks, Tasmina. Good. So before we proceed further, just to break the monotony, right? If you continuously learn biochemistry, it becomes too difficult. You might feel overwhelmed. So to answer one of your questions, somebody asked how to revise biochemistry, right? So to revise biochemistry, please don't start learning from the first, okay? One of the easier way of learning biochemistry is to work out previous year questions, okay? So you have question banks, right, which give you all previous year questions of biochemistry. Start working out those MCQs. Consider every MCQ as an MCQ which has happened or which has been asked in your final exam. Put in your entire brain into it. Put in all your efforts into it. Recollect all the facts that you have learned so far, because there is always a possibility of you feeling overwhelmed and you giving up at this point, okay? But please don't give up. No effort will go for waste, right? If you're watching this session for 3 hours, this 3 hours will never go wasted, right? Even if you think you've forgotten many facts already, when you start revising, it will come back to your support quickly, okay? So you should always have an open mind, right? And you should put in all your efforts to try answering every MCQ, and you try answering it by hook or crook method, you should try answering it. And after answering it, go to the explanation, try reading about it. And that is the best way of learning a subject, because you're not in your first year, right? If you're a first year student, I would say take a textbook, read every pathway, understand the pathway first, and then start applying. Your case is different. You've already finished your undergraduation. Though you think you did not learn biochemistry, you've learned a bit. Take it from you've learned a bit. Okay. So have that open mind, and you've already watched LRR session. You've watched this image-based MCQ. You have watched rapid revision videos of PrepLadder, because I know expecting you to watch the main video is too much of an expectation from my side, but I will be very happy if you try watching all those videos, but I know you don't have enough time to do that. So watch rapid revision videos, watch LRR session on PrepLadder YouTube channel, watch image-based questions. After that, start working out all previous year questions, learn in a retrospective manner, okay, and then take notes. Keep revising it every now and then, okay? That's the only way out. Okay, and you should never give up. Yes, even today, I forget many facts in biochemistry. When I say I'm not claiming to have a higher IQ. I'm not claiming to have a higher memory power. I said I because I've been teaching biochemistry since 2006. So this is my 19th year teaching biochemistry. Even now I forget facts, I forget concepts, okay? So human brain works in a peculiar way. It's happy to forget, but we have to overcome that. And that happens only with perseverance and grit, okay? So with perseverance, with grit, with discipline, I'm very sure you will be able to come up with flying colors, right? Without these three features, nobody can win. Do you get it? At this time, revising notes will be better, or watching important revision videos. I would say don't do both. Okay, I would say work out MCQs at this point, right? Working out MCQ is the only way out, because answering an MCQ is a skill that comes purely by practice. Okay, so work out as many MCQs as possible, because if you're watching a video, it's like passive learning, right? Okay, so watching, after you watch LRR, after you watch IBQ, don't again sit and watch more and more videos. Sit and start working out MCQs. That will be an active learning process. That is when your brain learns to recruit all nerves to retrieve the information. Do you get it? Okay, let's start learning now. A known patient of tuberculosis on INH, on INH for 6 months, presents with tingling sensation, paresthesia, and disturbing itchy, oily skin lesions as shown in the image. So how do you describe this? Seborrheic dermatitis, right? Seborrheic dermatitis, deficiency of which of the following vitamins? It is INH causes B6 deficiency. B6 deficiency presents with seborrheic dermatitis. So the answer is B6. Okay. So first, let me tell you what happens in INH. Why should there be B6 deficiency quickly? And then let's learn all about B6, all about high yield facts about B6. Okay. So INH is an aldehyde. Okay. INH is an aldehyde. So this INH actively inhibits pyridoxal kinase. What is the use of pyridoxal kinase? It converts pyridoxal to pyridoxal phosphate. It converts B6 to the active form of B6. That enzyme is inhibited by INH, and that is why INH causes B6 deficiency. Okay. Now, what can you expect whenever there is B6 deficiency? To understand that, you need to know the B6 dependent enzymes. Okay. So what are the B6 dependent enzymes? This is frequently asked, so all of you watch this carefully. B6 is necessary as a coenzyme for number 1, transaminases. It is necessary for number 1, transaminases. Let me give you an example of a transaminase. The example of a transaminase is ornithine aminotransferase. What is the role of ornithine aminotransferase? Ornithine aminotransferase acts on ornithine an amino acid and converts this amino acid into a keto acid. That keto acid is gamma glutamate semialdehyde. This way it enters into citric acid cycle. It comes out as carbon dioxide. Do you understand this? Ornithine aminotransferase acts on ornithine and amino acid, converts it into a keto acid, which is gamma glutamate semialdehyde, so that it enters into citric acid cycle, comes out as carbon dioxide. And this transaminase is dependent on pyridoxal phosphate. Now, what happens when there is a genetic defect of ornithine aminotransferase? Ornithine accumulates. This ornithine is toxic to retinal pigment epithelium. When retinal pigment epithelium is damaged, it causes gyrate atrophy of retina. Do you all understand this? Does that ring a bell? Have you all learnt about gyrate atrophy of retina? So tell me, what is the cause of gyrate atrophy of retina? It is because of the defect of ornithine aminotransferase. When that enzyme is defective, ornithine accumulates. That ornithine is toxic to retinal pigment epithelium. Okay. And that is why whenever you make a diagnosis of gyrate atrophy of retina, what should you supplement to those patients? Start supplementing them with B6. Because in that case, ornithine aminotransferase activity is stimulated, ornithine does not accumulate. So can you tell me one clinical condition? Yeah, can you all tell me one clinical condition that responds to B6 supplementation? Gyrate atrophy of retina, because all transaminases are dependent on B6. Okay. The next group of enzyme dependent on B6 is decarboxylases. Not only transaminases, decarboxylases are also dependent on B6. Let me give you an example of decarboxylase. The best example of decarboxylase is glutamate decarboxylase, which helps in the conversion of glutamate to GABA. What is the role of glutamate decarboxylase? It converts glutamate, an excitatory neurotransmitter, to GABA, which is an inhibitory neurotransmitter. And that is dependent on B6. That is why what happens whenever there is B6 deficiency, glutamate decarboxylase is inactive. What accumulates? Glutamate accumulates. GABA is not formed. There is excess excitatory neurotransmitter, low inhibitory neurotransmitter, and that causes seizures. Do you understand this? That causes seizures. So B6 deficiency causes seizures for this reason. To put it with a positive note, right? Whatever may be the cause of seizure, right? Give him or her a shot of B6. The seizure can be because of a fever. It can be because of a structural defect. It can be because of a metabolic defect that is immaterial. If you see refractory seizure, give B6. The moment you give B6, any glutamate that is in the synapse will get converted to GABA and the seizure activity will be brought down. So tell me, what is the second clinical condition that responds to B6 administration? Seizures. Another example for decarboxylase is ALA synthase. ALA synthase is an enzyme that is involved in heme synthesis. And that is a decarboxylase that is dependent on B6. That is why what happens in B6 deficiency, what will not be synthesized? Heme will not be synthesized. That causes anemia. So B6 deficiency also causes anemia. To put it in a positive note, whatever may be the cause of anemia, it can be an iron deficiency anemia. Don't just give iron, add B6 to it. Right? When you add B6 to it, ALA synthase is stimulated, heme is synthesized, and the anemia can be treated quickly. So tell me, what are the two clinical conditions that are responsive to B6 because decarboxylases are dependent on B6? One is seizure, the other one is anemia. Okay. The next one is kynurenase. Did I tell you about kynurenase? Yeah, what did I tell you about kynurenase is involved in the conversion of tryptophan to niacin. So whenever there is B6 deficiency, niacin cannot be synthesized. That causes pellagra. To put it in a positive note, whatever may be the cause of pellagra, right? Whatever may be the cause of pellagra, don't just give niacin, add B6 to it. The response will be better. So pellagra responds to B6 administration. The last enzyme which is dependent on B6 is cystathionin beta synthase. Cystathionin beta synthase is also dependent on B6. So what is the role of cystathionin beta synthase? All of you please listen to this carefully because I'm going to tell you about two clinical conditions here. Cystathionin beta synthase is involved in homocysteine metabolism. Okay. So homocysteine has got two fates. One is homocysteine gets converted to cysteine. The other one is homocysteine gets converted to methionine. Right? Homocysteine can either become cysteine or it can become methionine. Which enzyme converts homocysteine to cysteine? That is the enzyme that I told you about now. Cystathionin beta synthase. This cystathionin beta synthase is dependent on B6. Okay. This is the major fate of homocysteine. Tell me what is the major fate of homocysteine? It can become cysteine in the presence of cystathionin beta synthase, which is B6 dependent. The minor fate I already told you. I said homocysteine can become methionine in the presence of methionine synthase. This methionine synthase is dependent on what I told you. All of you please answer. This methionine synthase is dependent on methyl B12. This methyl B12 gets its methyl group from methyl tetrahydrofolate. Okay. So can you all tell me what are the causes of homocystinuria? Homocystinuria is either because of a defect of the major fate or it is because of the defect of the minor fate. If it is because of the defect of the major fate, it is called as type 1 homocystinuria. If it's because of the defect of the minor fate, that is called as type 2 homocystinuria. Do you understand this? So all of you tell me what is type 1 homocystinuria due to? Type 1 homocystinuria is because of the defect of cystathionin beta synthase. In this case, can you tell me what will happen to cysteine levels? When the block is here, cysteine will not be synthesized. Cysteine level will be low. And in contrast, the accumulated homocysteine gets converted to methionine. So in type 1, you see low cysteine and high methionine. Do you all understand this? In type 1, you see low cysteine and high methionine. What is type 2 homocystinuria due to? Because of the defect of which enzyme? Methionine synthase. When methionine synthase is defective, what is not formed? Methionine is not formed. The accumulated homocysteine becomes cysteine. So you will see low methionine and high cysteine. Do you understand this? So can you all tell me the differences between type 1 and type 2 homocystinuria? All of you tell me the differences between type 1 and type 2 homocystinuria. Type 1 homocystinuria is because of the defect of cystathionin beta synthase. And in type 1 homocystinuria, you see low cysteine and high methionine. Type 1 responds to B6 administration. Type 2 homocystinuria is because of the defect of methionine synthase. In this case, there is low methionine and high cysteine. Type 2 responds to B12 and folate administration. Okay, type 2 responds to B12 and folate administration. And that is why whenever you see homocystinuria, you don't have to struggle finding out whether it's type 1 or type 2. All that you will have to do is give B6, give B12, give folate. Whatever may be the cause, it gets diverted to other routes, the levels will be low. right? That is why to treat homocystinuria, you give B6, you give B12, you give folate. Okay? Yeah. Because homocysteine cross-links, homocysteine interferes with collagen cross-linkages. That is why it presents with skeletal deformities like flat foot, marfanoid features, ectopia lentis. Yeah, does that answer your question, Raghav? Raghav's question is, why does homocystinuria present with marfanoid features? Because homocysteine interferes with collagen cross-linkage formation. That is why you see many skeletal defects, right? You see flat foot, you see ectopia lentis, you see marfanoid features. So can you all tell me what are the B6 dependent conditions? Can I see the chat box to be active, please? Yeah, what are the B6 dependent clinical conditions? Gyrate atrophy of retina, seizures, anemia, pellagra, and type 1 homocystinuria. How many questions can we expect from this session? I wish that I have this ability to predict what can happen in the upcoming exam, right? But otherwise, because we are covering all topics, if not a direct MCQ, I can give you an assurance that 80% of the MCQs will be based on the topics that are being covered today. Do you understand what I'm saying? It will be based on the topics that are being covered. But then I want you to supplement this with, as I told you, LRR session. Please supplement this with PrepLadder rapid revision videos. In that case, more than 95% will be covered. Okay? I hope I answered your question. Can you answer this, please? A 45-year-old patient presented with joint pain, weakness, and sudden reduction in visual acuity. Patient is a known case of homocystinuria. Visual examination image is provided below. What do you see here? Do you see infranasal dislocation of lens? Yeah. Do you remember Marfan syndrome? Supratemporal dislocation of lens, homocystinuria, infranasal dislocation of lens. He has low homocysteine and cysteine. If you see low cysteine, which type is it? It is type 1. Type 1 responds to which vitamin? B6 administration. Good. A patient who has always neglected his nutrition presented with follicular hyperkeratosis on extensor aspect of the forearm, right? What is the diagnosis? What is your diagnosis, all of you? This is phrenoderma. And phrenoderma is a feature of vitamin A deficiency. You know that, right? Follicular hyperkeratosis. Why am I calling it as hyperkeratosis? Because I see keratin plug at the tip. And follicular hyperkeratosis of phrenoderma is a feature of vitamin A deficiency. Okay. So, can you all tell me the various forms of vitamin A? What are the various forms of vitamin A? The alcohol form retinol, the aldehyde form retinal, and the acid form retinoic acid. Right? Retinol, retinal, and retinoic acid. And what is the significance of the alcohol form retinol? This is the form in which vitamin A is absorbed. This is the form in which vitamin A is transported and is stored. This can be asked as a one-liner. In which form is vitamin A absorbed, transported, and stored? It is the alcohol form retinol. Okay. And then retinal. In retinal, you see retina. Yeah, in the term retinal, you see retina, right? So retina means eye. So this is the form that is present in eye. When I say it's present in eye, this is the form that is present in rhodopsin. In rhodopsin, it is present as levensis retinal in the center. In rhodopsin, it's present as levensis retinal in the center that is surrounded by opsin. So retinal is the one that is present in eye as rhodopsin. It is levensis retinal in the center surrounded by opsin. Now retinoic acid. There are two types of retinoic acid. One is all trans retinoic acid. The other one is 13-cis retinoic acid. Okay. All trans retinoic acid helps in growth and differentiation of cells. Yeah, it helps in growth and differentiation of cells. Whereas 13-cis retinoic acid helps in suppressing keratinization of epithelium. Do you understand this? It helps in suppressing keratinization of epithelium. That is why what happens in vitamin A deficiency, there is no suppression of keratinization of epithelium. Everywhere there is keratinization. When there is keratinization of the skin, that causes toad skin or follicular hyperkeratosis or phrenoderma. Do you understand this? So that is about this question. It is phrenoderma caused by vitamin A deficiency. Specifically, which form of vitamin A? It is 13-cis retinoic acid. A very simple MCQ, NEET 2023. Can you all answer this? Yes, AML M3 responds to all trans retinoic acid. Answer this, please. Bowlegs, rickets, vitamin D deficiency. Okay, so such a simple MCQ was asked in NEET PG 2023, making you to answer this question quickly. But this is a warning that is given to you that in the next year you can expect a complex question based on this. Okay, that is why I've told you whenever you work out previous year MCQ, don't just read the question, find out the answer, be satisfied with that. If you see a question like this, you should read in and out about rickets, because look at this. In NEET PG 2024, this question was asked. Okay, a child presented with the following deformity, biochemical investigation is given below. What is the biochemical investigation? Serum calcium is normal, parathormone is normal, phosphate is low, ALP is raised. What is the probable defect? What is your answer, everybody? The clue that is given here. This year NEET will be very tough, says Ananda Patil. I don't want you to be pessimistic. I don't want anybody here to be pessimistic, right? But in a way it is good, right? Always expect the worst so that you are able to face it with confidence. Okay, but I would say nothing matters. How questions are asked will not matter at all, right? Provided you know how to answer it. Okay, provided you have learned everything conceptually. Okay, so let's try to answer this question. The clue that is given to you here is PTH is normal. The moment you see rickets with normal PTH, go for hypophosphatemic rickets. Okay, go for hypophosphatemic rickets. Why is it not vitamin D deficiency? It's because what do you expect in vitamin D deficiency? Let me help you answer this. 1 second. I don't know what has happened. Okay, so what happens in vitamin D deficiency? Please watch this because they've been asking you about hypophosphatemic rickets multiple times. Okay, so whenever there is vitamin D deficiency, what happens to blood calcium and blood phosphate? Momentarily, both calcium and phosphate will be low. The moment blood calcium is low, there will be feedback stimulation of parathormone. Right? Whenever there is low calcium, there will be feedback stimulation of parathormone. This is what we call as secondary hyperparathyroidism. So tell me one cause of secondary hyperparathyroidism, vitamin D deficiency, because there is low calcium. When there is hyperparathyroidism, you know that parathormone increases calcium reabsorption and it causes phosphate secretion. Even if you don't remember this till now, please memorize it now. What is the role of parathormone? Parathormone causes calcium reabsorption and it causes phosphate secretion. What happens whenever there is an increase in calcium reabsorption? When there is an increase in the calcium reabsorption, the low calcium that was observed initially becomes normal. That is why in most cases of vitamin D deficiency, calcium levels will be normal or at least near normal. Why do you see normal calcium or near normal calcium in vitamin D deficiency? Because of secondary hyperparathyroidism. Okay. But what happens to phosphate level? Already the phosphate level is low because of vitamin D deficiency. The secondary hyperparathyroidism causes further reduction in phosphate level. And that is why in vitamin D deficiency, phosphate levels are always low. Do you all understand this? So can you all tell me the biochemical features of vitamin D deficiency? All of you answer this. In vitamin D deficiency, calcium levels will be normal. Phosphate level will be low, both because of secondary hyperparathyroidism, right? Whenever there is secondary hyperparathyroidism, ALP level will be high. Secondary hyperparathyroidism or any defect in the bone, mineralization defect in the bone, ALP level will be high. So these are the biochemical features of vitamin D deficiency. Now, what are the causes of vitamin D deficiency? Obviously, nutritional vitamin D deficiency, or it is because of vitamin D dependent rickets type 1, or it is because of vitamin D dependent rickets type 2. Okay, nutritional deficiency is self-explanatory. The person has not taken vitamin D properly or has not been exposed to sunlight. That is nutritional deficiency. Now, what is vitamin D dependent rickets type 1 due to? Type 1 is because of the defect of 1-alpha hydroxylase enzyme, which helps in the formation of active form of vitamin D. Which is the active form of vitamin D? 125 dihydroxy vitamin D is the active form. That is formed by 1-alpha hydroxylase. If that activity is low, it is type 1. 1 is 1-alpha hydroxylase, low activity. What is type 2? Type 2 is a receptor defect. Whenever vitamin D receptor is defective, that is called as type 2. Okay. In all these three cases, what will you see? Same biochemical features. What are the biochemical features that you will see? Just now I told you. Normal calcium, low phosphate, high parathermone, high alkaline phosphatase. So how will you differentiate these three conditions? You can differentiate these three conditions by estimating 25 hydroxy vitamin D. Normally, when you go and give your blood sample for vitamin D estimation, they estimate 25 hydroxy vitamin D. If you estimate that value, in nutritional vitamin deficiency, this value will be low. Okay, whereas in vitamin D dependent rickets type 1 and type 2, 25 hydroxy vitamin D levels will be normal or high. Logical, right? In nutritional deficiency, the value will be low. Whenever there is 1-alpha hydroxylase defect or receptor defect, the 25 hydroxy vitamin D levels will be normal or high. That is how you can find out whether it is nutritional deficiency or D dependent 1 or 2. Okay. How will you find out whether it is 1 or 2? To find out whether it is 1 or 2, you estimate 125 dihydroxy vitamin D levels. When you estimate 125 dihydroxy vitamin D levels, if the value is low, then that is vitamin D dependent rickets type 1. If the value is low, it is type 1 because 1-alpha hydroxylase activity is less. If the value is high, it is a receptor defect. If the value is high, it is a receptor defect. Are you clear so far? Yeah. So can you exclude choices here? What are the choices that you have excluded already? Because PTH value is normal, I am going to exclude nutritional vitamin D deficiency. I am going to exclude dependent rickets type 1 and type 2 because I know in all these conditions there will be secondary hyperparathyroidism. So what is my answer here? My answer here is hypophosphatemic rickets. But this is not enough, right? You will have to know what is hypophosphatemic rickets. Why is PTH level normal in this condition? Okay, because we are going to learn everything conceptually. Okay, so please, all of you, don't learn anything in a factual manner. That will never help you. Always ask yourself why. Try to find out the answer. That case, you will never forget. Okay, so what is hypophosphatemic rickets due to? It is because of FX gene mutation. Yeah, it is because of FX gene mutation. FX gene codes for a protein. That protein has two functions. One is it degrades FGF23. One is it degrades FGF23. Second is it degrades osteopontin. These are the two functions. What is the function of FGF23? FGF23 has phosphaturic effect. It causes phosphate to be secreted. What is the function of osteopontin? Osteopontin inhibits bone mineralization. Osteopontin inhibits bone mineralization. So what does FX gene help you when? FX gene avoids phosphaturic effect. It supports bone mineralization. When there is mutation, what will happen to FGF23 values? Increases. There is high FGF23, so phosphaturic effect happens. When there is phosphaturic effect, that causes hypophosphatemia. That is why the name hypophosphatemic rickets. Whenever there is hypophosphatemia, bone mineralization defect happens because bone mineral is calcium phosphate. When there is low phosphate, there will be bone mineralization defect. Whenever there is bone mineralization defect, ALP level will be high. So here you see low phosphate, high ALP. Okay. And whenever there is inhibition of bone mineralization, again you see rickets-like manifestations. But what will happen to parathormone level and calcium? There will be normal calcium, right? There will be normal calcium, there will be normal parathormone. Do you all understand this? Normal calcium and normal parathormone. So the take-home message here is, when 25-hydroxy vitamin D level is low, it is nutritional vitamin D deficiency. When 25-hydroxy vitamin D level is normal, you estimate 125 dihydroxy vitamin D level. If that is low, it is vitamin D dependent rickets type 1. If that is high, it is type 2. Okay. This you will do if parathormone levels are high. But if you see rickets-like manifestations with normal parathormone, close your eye and say it is hypophosphatemic rickets. Are you clear? So let's now learn clinical biochemistry. A 26-year-old male with colicky pain. Can we have a break now? Because I think I have to adjust the slide a bit. Yeah. So you can also go have some coffee or tea and come back. I will resume the session in 5 minutes. Can we start? So I saw that many of you had already answered this question. 26-year-old male with colicky pain and the crystals in urine picture is given. Which of the following is the diagnosis? So what you see here is a hexagonal crystal, right? Hexagonal, 6 sides. 6 sides stands for cis, right? 6 sides stands for cis. It is cystinuria. Okay. Now let's learn about other renal stones and the crystal images. What if you see a rhomboid crystal like this? Yeah, what if you see a rhomboid crystal like this? In rhomboid, do you see U here? Right? In rhomboid, you see U. U stands for urate crystals. So rhomboid crystals are urate crystals. What if you see an envelope shaped crystal like this? In this envelope, what do you see in the center? X. Right? X stands for oxalate. Envelope shaped crystal is oxalate crystal. It is calcium oxalate dihydrate. It is calcium oxalate dihydrate stones which are envelope shaped. What if you see a dumbbell shaped crystal? Can you see that here? Dumbbell shaped crystal is calcium oxalate monohydrate stones. Okay. If you see flat wedge shaped crystals like this, flat wedge shape, it is calcium phosphate stones. Okay. The next one is, you know this, right? Coffin lid appearance. Coffin lid appearance is something which is severe. So when do you see a severe condition? Struvite stones. Staghorn calculus, right? Staghorn calculus, the entire pelvic calyceal system is loaded with stone. Staghorn calculus is a very severe thing, that is coffin lid appearance, and that is MAP crystal, triple phosphate crystal, right? And this is seen whenever a person is infected with a urease producing microorganism, magnesium ammonium phosphate crystal, struvite stones present with coffin lid appearance. Yes, alkaline urine. So what is answer here? 6 sides is cystinuria. Okay. Next one. Lipoprotein electrophoresis of a patient presenting with chronic kidney disease, corneal opacity, low HDL is provided here. The band identified as A. Where do you see A here? The A is here. Okay. And whenever you see electrophoresis pattern, you have to find out which is the point of application, right? Wherever you see a negatively charged electrode, that will be the point of application. That is, a serum or plasma is applied close to the negatively charged electrode. So what you see here as A is a band that is close to the point of application. And what is the answer here? I would first exclude M band or multiple myeloma. I will not see M band or multiple myeloma on lipoprotein electrophoresis, because in lipoprotein electrophoresis, I would stain it with oil red O, which stains only lipids, right? It is not going to stain my protein. It's lipoprotein electrophoresis. So this is not M band or multiple myeloma. Okay. So now I have 3 choices. I know the right answer is lipoprotein X and complete LCAT deficiency because of the clinical features. Clinical feature says corneal opacity, right? Corneal opacity is fish eye disease. Corneal opacity is fish eye disease. I have already asked you to remember fish and cat. Have you seen cartoons? In all cartoons, cats are shown as if they eat fish, right? So whenever you see fish eye disease or corneal opacity, it is cat, LCAT deficiency. So the answer is lipoprotein X and complete LCAT deficiency. But now I'm going to tell you all about lipoprotein electrophoresis. Okay, so I'm going to tell you how to interpret lipoprotein electrophoresis image. Okay, so how is the lipoprotein electrophoresis done? It is always run on a glass slide. On this glass slide, we apply the serum lipoprotein of which has to be separated. And then I connect close to the point of application is connected to a negatively charged electrode. The opposite side is connected to a positively charged electrode. So that when I switch on the electric current, all my lipoproteins will start migrating towards positively charged electrode. The migration will be affected by the number of negative charges these lipoproteins carry, and it will be affected by the size. If the number of negative charges is more, it will rapidly move towards oppositely charged electrode. If the size is small, it will rapidly move towards oppositely charged electrode. So in lipoprotein electrophoresis, migration is affected by number of negative charges. Migration is affected also by the size. That way, the band that is present farthest from the point of application, farthest from the negatively charged electrode, is called as the alpha band. The band that is present farthest from the point of application is called as the alpha band. This alpha band has got HDL. So why does HDL move the fastest? Because HDL has got the highest negative charges and HDL moves the fastest. Okay, so HDL is otherwise called as alpha lipoprotein because it has got the highest negative charge. In contrast, the lipoprotein which cannot move at all because of its largest size is chylomicron. So where will you see the chylomicron band? Chylomicron band is supposed to be present at the point of application if at all it is present. Why am I saying if at all it is present? Because for lipoprotein electrophoresis, you should run only a fasting sample. And fasting sample does not have chylomicron, which is a result of dietary triacyl glycerol. So in a normal person, when you run lipoprotein electrophoresis, you should not see a band at the point of application. But if you see a band at the point of application, then there are two reasons. One is familial chylomicronemia syndrome. Right? One is familial chylomicronemia syndrome, wherein the chylomicron levels are naturally elevated. Otherwise, it is because of lipoprotein X. So, what is lipoprotein X due to? Lipoprotein X is due to LCAT deficiency. X and C, right? They look similar. Lipoprotein X is because of it. Lipoprotein X and LCAT. So lipoprotein X is because of LCAT deficiency. What is the function of LCAT? LCAT helps in the conversion of discoidal HDL to spheroidal HDL. Please memorize it. It's a high yield session. I cannot explain this any further. Just remember LCAT helps in the conversion of discoidal HDL to spheroidal HDL. So whenever there is LCAT deficiency, there is no spheroidal HDL. So HDL levels will be low. As given in the history, HDL level will be low in LCAT deficiency. When HDL level is low, reverse cholesterol transport cannot happen. So in all extrahepatic tissues, cholesterol accumulates. When cholesterol accumulates in the cornea, that causes corneal opacity. That is why the name fish eye disease. Okay, not just that, which HDL accumulates, the discoidal HDL accumulates. When discoidal HDL accumulates, on chronic accumulation, this discoidal HDL takes a lamella shape, which is very huge. Because the size is huge, it cannot migrate. That is why it is present at the point of application. Okay. Another reason for lipoprotein X, one reason for lipoprotein X is LCAT deficiency, which presents with fish eye disease and low HDL. Another reason for lipoprotein X is obstructive jaundice. Even in obstructive jaundice, when there is an obstruction, bile salts overflow into the circulation. These bile salts also take up a big structure, which is seen at the point of application. So all of you listen to this. On lipoprotein electrophoresis, if you see a band at the point of application, then what are the possibilities? One is familial chylomicronemia syndrome. The other one is lipoprotein X due to LCAT deficiency or lipoprotein X due to obstructive jaundice. Are you clear? Yes. So this is about what if you see a band at the point of application. Apart from this band at the point of application, closer to this you will see a beta band. This beta band is because of LDL, right? Beta band is because of LDL. The next band or the band that moves ahead of LDL, the band that moves ahead of LDL or the beta band is called as the pre-beta band. This pre-beta band has got VLDL. Do you understand this? Pre-beta band has got VLDL. So in a normal person's lipoprotein electrophoresis, listen to this. In a normal person's lipoprotein electrophoresis, we see 3 bands, right? The first band, farthest from the point of application, is alpha band or HDL. Relatively closer to the band is beta band or LDL. Between alpha and beta band, you see a pre-beta band, which is VLDL. Okay, I did not mention anything about remnant lipoproteins. I did not mention about remnant lipoproteins because the concentration of remnants in a normal person is too low to be detected on electrophoresis. Otherwise, if you detect them based on the migration, this is where you should see the band. Can you see a gray band that I've drawn here? That is where remnants are expected to be found, but normally you don't find it. So what happens in type 3 hyperlipoproteinemia? Okay, type 3 hyperlipoproteinemia is otherwise called as remnant disease because here remnants accumulate. So in this condition, remnant concentration increases, making the beta band broader. Do you understand this? Making the beta band broader. That is why it is called as broad beta disease. So if you see a broad beta band, then what is your diagnosis? Your diagnosis is type 3 hyperlipoproteinemia. So can you tell me what are the diagnostic applications of lipoprotein electrophoresis? One diagnostic application is familial chylomicronemia syndrome, when you see a band at the point of application. Lipoprotein X because of LCAT deficiency, lipoprotein X because of obstructive jaundice. In all these cases, you see a band at the point of application. Another diagnostic application is if you see a broad beta band, that is broad beta disease or type 3 hyperlipoproteinemia, wherein remnant concentration increases. Okay, good. So what is the right answer here? So this is the negative electrode. This is the point of application. If this is the point of application, the band farthest from the point of application is alpha band. This is normal alpha band with HDL. Do you see that this alpha band is lighter? All of you say yes or no. In your patient, the alpha band is lighter, indicating that the HDL level is low. Apart from this, you see a band at the point of application, that is lipoprotein X because of LCAT deficiency. Okay. The tube that is used for serum electrolyte estimation is, this is an INI-CET November 2024 MCQ. Can anybody answer this? Serum is one clue. Electrolyte is another clue. Yeah, many of you are answering it as green. I have already given you the answer multiple times. For serum, you cannot use green because what does green have? Green has heparin. Heparin is an anticoagulant. The moment you place an anticoagulant, it is plasma. Right? Green has heparin, which is an anticoagulant. What separates above is plasma. So it's not green. It is yellow, right? What do we spray in an yellow tube? In a yellow tube, you spray a clot activator. So after clotting, what separates above is serum. So what is the right answer here? The right answer here is yellow. Okay, yes. So let's learn about blood collection tubes now. We have discussed about this so many times. Okay, so I want all of you to answer this. The first image, all of you tell me what color cap do you see here? Red color cap. For red color, what is the mnemonic I've given you? RSS. What does R stand for? Red. What does S stand for? Silica. What does S stand for? Serum. What is silica? Silica is a clot activator, right? So clot activator activates clot, and what separates above is serum. So RSS, red silica serum. Okay, so all of you answer this. What are the differences between serum and plasma? Can anybody answer this? What are the differences between serum and plasma? If you collect a blood sample in which you're placed an anticoagulant, if you're placed an anticoagulant, what separates above is called as plasma. So plasma is separated after placing an anticoagulant. What is serum? If I collect blood sample in a simple tube, the negative charges of the tube stimulate in vitro clotting. After in vitro clotting, what separates above is called the serum. So serum is something which separates after clotting. So serum does not have clotting factors. Are you clear? Serum does not have clotting factors. Serum does not have fibrinogen. Okay, so when are we going to use plasma? When are we going to use serum? Listen to me carefully. When do we need an anticoagulant? Whenever you need a whole blood sample, right? Whenever I need a whole blood sample, if I allow clotting to happen, can I mix it to get the whole blood sample? I cannot. So when do I need a whole blood sample? Whenever complete blood count has to be estimated. What do you mean by complete blood count? I want to estimate the number of RBCs. I want to estimate the number of WBCs. In which case, if I allow clot to happen, all cells will be trapped in the clot. So I cannot individually count all those cells. So for complete blood count, which is done in pathology, I want the cells to be intact. I don't want the cells to be trapped in the clot. That is why I'd add an anticoagulant. Right? And what is the anticoagulant that I add? I add either K3-EDTA or I add K2-EDTA. K2-EDTA is the latest. Do you understand this? K2-EDTA is the latest because it does not affect many parameters. So this has got a lavender color cap. So have you all collected blood sample in a lavender color cap? Lavender color cap meaning it has got K3-EDTA or K2-EDTA. EDTA chelates calcium, does not allow clotting to happen. So what is separated above is called as plasma. I collect blood sample. In the lab, I mix the blood sample. I get a whole blood sample. I introduce the whole blood sample into the machine. The machine separates all the cells individually, counts all the cells individually, and will give me my values. That is why for complete blood count, it has to be a lavender top tube. Not only for complete blood count, even for HbA1c estimation, glycated hemoglobin. For me to estimate glycated hemoglobin, I want my RBCs to be intact. I don't want my RBCs to be trapped in a clot. So I should avoid clotting. What do I add? K2-EDTA or K3-EDTA. In the lab, I receive the sample, I mix the sample, I add a hemolysate. It allows RBCs to be lysed. Hemoglobin comes out. I measure glycated hemoglobin and I give the value. So for complete blood count for HbA1c or whenever labile parameters like parathormone or ACTH or ammonia need to be estimated. Right? Whenever labile parameters like parathormone, ACTH or ammonia will have to be estimated. What do I mean by labile parameters? After sample collection, proteases in the sample will degrade all these labile parameters. In this case, I don't want my proteases to be acting after sample collection. How can I inhibit proteases? By chelating calcium. The moment I chelate calcium, enzymes become inactive. Proteases are not active. So labile parameters are preserved. They are protected. So can you all tell me, when will I use lavender top tube? When will I use EDTA tube? Whenever I need whole blood sample, complete blood count, HbA1c, whenever labile parameters like parathermone, ACTH or ammonia need to be estimated. Okay, that is why what we did was, initially we used to collect blood sample in a glass tube, simple glass tube. Then we thought we have to add anticoagulant like K2-EDTA or K3-EDTA, okay, for all these purposes. Now, why not we use K2-EDTA sample or K3-EDTA sample for biochemistry also? I cannot, right? I cannot use this for biochemistry. If I'm trying to use this for biochemistry, my potassium levels will be high. It is K2 or K3-EDTA. Potassium level will be high. Calcium level will be low. EDTA is chelated calcium. All my calcium levels will be low. Not just that, all my enzymes will be low. All enzymes are dependent on calcium. I cannot estimate liver function test, right? I cannot do liver function test. AST, ALT levels will be low. Amylase level will be low. Lipase level will be low. Creatine kinase level will be low. I don't want any of these interferences by these anticoagulants. That is why I decided to use in my biochemistry lab a serum sample. Right? After deciding to use serum sample, when I collected blood sample in my plastic tube, right, it did not allow clotting to happen quickly. So I had to wait for a long time. I didn't want to wait for a long time. So I added a clot activator, right? What is a clot activator that I add here? I add silica. So when I add silica, it quickly it quickly allows clotting to happen. Quickly serum gets separated so that I can quickly estimate renal function test, liver function test, electrolytes, hormones, anything which I want in biochemistry can be estimated if there is a clot activator with a red top. Do you all understand this? Yes? Yes. So that is about when to use red top. Red top has to be used in biochemistry. Lavender top has to be used in pathology. When will you use lavender in biochemistry? I use lavender in biochemistry when I want HbA1c. I use lavender in biochemistry when I want parathermone, ACTH or ammonia, not otherwise. Okay. Now what color do you see here? Gray color. G, gray for G. Gray color tube is for glucose estimation, because gray color tube has sodium fluoride and potassium oxalate. Right? Gray color tube has sodium fluoride and potassium oxalate. It's a fluoride tube. Fluoride inhibits enolase. Right? Fluoride inhibits enolase, does not allow RBCs to use glucose after sample collection. If you allow RBCs to use glucose after collection, it will give you false low values. So whenever you're estimating fasting plasma glucose, whenever you're estimating postprandial plasma glucose, collect blood sample in a gray top tube with fluoride which inhibits enolase to avoid false low values. Are you clear? G for G, gray for glucose. This we know, right? All of you tell me, what is this tube? Lavender tube, K2 or K3-EDTA. What is it used for? Complete blood count, HbA1c, parathermone, ACTH and ammonia. Now, blue top tube. What is a blue top tube? It's a citrated tube. The citrated tube has got 3.2% sodium citrate. Right? Citrated tube has got 3.2% sodium citrate. C for C, coagulation assays. Whenever you have to estimate prothrombin time, activated partial thromboplastin time, fibrinogen assays, factor assays. Right? For all these, we have to use a citrated tube. Okay, C for C, citrated for coagulation. Green. I already told you, green tube has got heparin. What do we use heparin tube for? Heparin tube has got two applications. One is for STAT biochemical analysis. Right? STAT meaning quicker biochemical analysis. For example, you see that a patient has got ECG changes. I want to know the potassium value. Right? If I'm going to collect blood sample in a red top tube, though there is a clot activator, it needs at least 60 minutes for the clot to get stabilized. Only after that I can centrifuge. I don't have the luxury of time here. I have to quickly estimate potassium and give the value, right? Or if I want troponin levels to be estimated, there's a very narrow window period. I cannot collect blood sample in red tube and tell the clinician that I'm waiting for the clot to get stabilized, right? So for quicker biochemical analysis like electrolyte estimation or for troponin estimation or intraoperative parathormone estimation, for that we use heparinized tube, wherein quickly the sample can be centrifuged and analysis can be done. Okay. Otherwise, it is used in genetics, for molecular diagnostics and for cytogenetics, because heparin does not affect DNA, does not affect RNA. For molecular diagnostics and cytogenetics, whenever DNA or RNA has to be extracted, we can collect a blood sample in a green topped tube. So green top tube is heparin for STAT biochemical analysis and for molecular diagnostics and cytogenetics. This is the last one. Right? This is the question, yellow color. And in yellow top tube, please remember this image. What do you see in the bottom? A gel. So what is this? This is gel and clot activated tube. Meaning at the bottom of the tube, there is a gel and it is sprayed with a clot activator. So what is the difference between a red top tube and yellow top tube? Both have a clot activator. Red does not have a gel, yellow has a gel. What is the use of gel? When there is a gel, you collect blood sample into this tube. When you collect blood sample will stay above the gel. Okay? But when you centrifuge, the gel will rise up. Because of differences in sedimentation coefficient, after sample collection, when you centrifuge, the gel will come up and it acts like a mechanical barrier between cells in the bottom and serum on the top. Do you understand this? Between cells in the bottom and serum on the top. So that anything which happens in the cell layer does not affect the serum. Because in due course, cells undergo lysis. Right? In due course, cells undergo lysis. Intracellular fluid will contaminate the serum. When intracellular fluid contaminates the serum, potassium levels will be falsely high, because intracellular fluid is rich in potassium, right? And all other values will be low, because intracellular fluid has diluted the serum, all other values will be low. I don't want all these false high and false low values. That is why I add a mechanical barrier. When will I add a mechanical barrier? Whenever sample has to be transported for a prolonged period of time, or whenever the sample has to be stored for a prolonged period of time, I need a gel and a clot activated tube. So all private laboratories which have satellite collection centers or home collection, they collect blood sample in a gel and a clot activated tube. Even when phlebotomists come to your home for collection, they come with the yellow top tube which has a gel, because they don't know at what time they'll be able to reach the lab, at what time the sample will reach the lab. By the time the cell should not lyse and should not contaminate the supernatant. Do you all understand this? So that is about, yeah, clot activator and gel tube. So a quick recap, all of you. What is this tube used for? Red, RSS, red. All of you, please keep the chat box active. So red, serum, silica. Okay. It is used for biochemistry. Gray top tube. G for G, it is for glucose estimation. Right, G for G, glucose estimation. It has got sodium fluoride and potassium oxalate. Lavender top tube, K2 EDTA or K3 EDTA, used for complete blood count, HbA1c, parathormone, ACTH, and ammonia. Blue top tube, citrated tube, used for coagulation assays. Green top tube, heparinized tube for stat biochemical analysis number 1, and it is used for molecular diagnostics and cytogenetics. Gel and clot activated tube is used whenever the sample has to be transported or the sample has to be stored. ABG, it is not a tube. For ABG, it is a syringe. Right? Heparinized syringe has to be used for ABG. So used for serum electrolyte estimation. Can you use a lavender tube for electrolyte estimation? K2 EDTA, potassium will be high. EDTA, calcium value will be low. So this is excluded. Can you use a gray top tube? Gray top tube has sodium fluoride. Sodium will be falsely high. Potassium oxalate, potassium value will be falsely high. So it is not gray. Why not green? Green has heparin. It is plasma electrolyte estimation. So what is the right answer, everybody? Yellow. Fasting glucose and postprandial glucose, Twinkle's question is, can we use a red top tube? You can use a red top tube if it's a if the time taken between sample collection and sample analysis is less than 90 minutes, right? In hospitals, in patients, right? In patients, you're collecting sample, you're going to send it to the laboratory, which is right inside the hospital. You know, the moment it reaches the hospital, they are going to centrifuge it, they are going to give you the value. In that case, you can collect it in a red top tube. Not when it is a lab, right? Not when it is a home collection. In all these cases, there will be false low values. Do you get it, Twinkle? Another question based on the tube, which anticoagulant is ideal for blood sample for HbA1c estimation? For HbA1c, it is EDTA. Try to answer this. 1 ml of ninhydrin reagent was taken in 3 test tubes. Okay, few drops of solution A, B, and C were added to 3 test tubes and were kept in a boiling water bath. The resultant color is shown. What is solution A, solution B, and solution C? What is the right answer, everybody? All that you will have to know is ninhydrin gives a purple color with amino acid. Right? Ninhydrin gives a purple color with amino acid. It gives yellow color with amino acid. It gives no color with carbohydrates. So A is an amino acid, C is an amino acid, B is a carbohydrate. With that clue, can you give me the right answer? C has to be proline. Where do you see proline? Choice C. Okay. And what is A? A has to be an amino acid. Lysine is an amino acid. Fructose does not give any color. So the right answer is choice C. Are you clear? So ninhydrin gives a purple color with amino acid, yellow color with amino acid, no color with carbohydrate. That is the concept here. Okay. This is a test used to detect the presence of protein. Can you all first tell me the test name? Which test is used to detect the presence of protein? Blue becomes purple. It is Biuret test. The test that is shown here is Biuret test. And Biuret test is used to detect any compound which has 2 or more peptide linkages. Bi meaning 2. right? So it is used to detect any protein which has got 2 or more peptide linkages, meaning it should have 3 or more amino acids. So Biuret test is answered by tripeptides and above. Tripeptide meaning it should have 3 amino acids with 2 peptide linkages. So any compound which has got 2 or more peptide linkages can react with copper sulfate in strong alkaline medium. The alkaline medium has to be provided by sodium hydroxide in the presence of sodium potassium tartrate. In the presence of sodium potassium tartrate to give a purple color. So these are the facts that you need to know about Biuret. Biuret is not only answered by proteins, it is answered by anything which has got 2 or more peptide linkages. Tripeptides and above react with copper sulfate in strong alkaline medium provided by sodium hydroxide in the presence of sodium potassium tartrate to give a purple color. It is also answered by a compound called as Biuret. Hence the name Biuret test. What is Biuret? Urea. Urea on heating gets converted to Biuret. This Biuret has 2 peptide linkages that can also answer this test. Hence the name Biuret. Based on this concept, can you start answering these choices? Right? Can you start commenting about these choices? Tell me about choice A. What is the composition of Biuret test? Biuret test composition is copper sulfate, sodium hydroxide, sodium potassium tartrate. So A is false. Does proline give a positive result? No. Proline is an amino acid. It does not have even one peptide linkage. So it cannot answer Biuret test. B is false. It is not answered by dipeptides. All of you tell me what are dipeptides. Dipeptides have 2 amino acids linked by one peptide linkage. Yes, dipeptides cannot answer Biuret test. Only tripeptides and above can answer it. So C is a true statement. Urea does not answer Biuret test is false because urea on heating can answer this test. So what is the right answer here? The right answer here is choice C. It is not answered by dipeptides. It's answered by tripeptides and above. Okay. But I'm going to also help you understand the differences between Benedict's reagent and Biuret reagent, which can be asked as one-liners because the chemical composition is almost the same. Both are blue in color because both have copper sulfate. Right? Both are blue in color because both have copper sulfate. Both provide alkaline medium. In Benedict's, alkaline medium is provided by sodium carbonate. In Biuret, it is provided by sodium hydroxide. Okay. In Benedict's reagent, it is sodium citrate. In Biuret reagent, it is sodium potassium tartrate. So can you tell me the differences between Benedict's reagent and Biuret's reagent? The first difference is Benedict's reagent is used to find out the presence or absence of what, all of you? Reducing sugars. Right? Benedict's is used to find out the presence or absence of reducing sugars. Biuret is answered by tripeptides and above. And both have copper sulfate. In Benedict's reagent, it is sodium carbonate. In Biuret reagent, it is sodium hydroxide. In Benedict's reagent, it is sodium citrate. In Biuret's, it is sodium potassium tartrate. Okay. So now, genetics. Okay. So this will be the last topic for you. And I want to discuss about genetics as image-based questions because there is a very high probability that you are asked image-based question in genetics. Okay. So look at this. The temperature at which step B in PCR happens is. So what have they shown you? This is the first cycle. Then it goes through second cycle. In first cycle, it is 2 copies. In second cycle, it has become 4. In the third cycle is 2 to the power of 3, which is 8. Then it becomes 16, 32, and so on. Okay. And every cycle has 3 steps. Okay. And in the second step, do you see that they have added primers? This is why I said image-based questions are cool. Why are image-based questions cool? Because you'll find answers there, right? So what do you see here? In B, they have added primers. And these primers have gone and annealed. They have gone and annealed to the flanking sequence. So what is step B? Step B is annealing step. Step C, it has elongated. So what is step C? Step C is elongation. So what is step A? Step A is denaturation. So tell me, what are the 3 steps of every cycle of PCR? In every cycle, there are 3 steps. The first one is denaturation. Second one is annealing, wherein primers anneal. Third step is elongation. Okay. Denaturation is carried out at 94 or 95 degree. Because for denaturation or unwinding to happen, the temperature has to be high. So denaturation is 95 degree. Okay. Annealing. Annealing has to be 5 degrees less than the melting temperature of your primers. Annealing is not fixed. Annealing temperature is, I will tell you why later. For now, annealing temperature is 5 degrees less than the melting temperature of your primers. It is variable. Elongation is carried out at 72 degree. Right? Elongation is carried out at 72 degree. So what is the answer here? The temperature at which step B in PCR happens is, step B is annealing. The temperature is variable. Okay. So can we learn a bit about PCR? Because based on that, I'm going to show you NEET PG 2024 MCQ and you're going to answer it. Okay. So facts about PCR. Can anybody define PCR? What is PCR? PCR is an amplification process. Because didn't I show you that in PCR, from 1 copy you get 2. From 2 you get 4. From 4 you get 8. So you're amplifying fragments. So what is PCR? PCR is an amplification process. For this amplification, I'm going to add 2 adjectives. One is, it is in vitro amplification. Why am I calling it as in vitro? Because it's happening in a test tube. PCR is happening in a PCR tube. So it is in vitro amplification. It is not happening in a cell. The second adjective is, it is in vitro amplification of a desired fragment of DNA. In PCR, are you randomly amplifying something? No. In PCR, I amplify only my desired fragment. How do you tell the PCR reaction that this is your desired fragment? I tell the reaction that this is my desired fragment by choosing specific primers. Right? How do I choose specific primers? I choose specific primers in such a way that they are complementary to the flanking sequences of the desired fragment. I'm not randomly choosing some primer. I choose primers in such a way that they are complementary only to the flanking sequences of the desired fragment so that I get exactly what I want. Are you clear, everybody? So all of you tell me, can you define PCR? Yeah, PCR is in vitro amplification of a desired fragment of DNA made possible by choosing specific primers which are complementary to the flanking sequences of the desired fragment. Okay, to explain this, I am going to show you steps of PCR. I want you to follow these steps of PCR, imagining that you're going to amplify albumin gene. Right? What are we trying to amplify? We are trying to amplify albumin gene. What is shown to you here is a chromosome which has albumin gene. The red color seen in the center is albumin gene. The black line represents the entire chromosome where you have the albumin gene. Okay. So to get exactly albumin gene in multiple copies, I'm going to subject this chromosome to PCR. I know PCR is a replication process. And I know for any replication, the first step is unwinding. So what have I done here? I've unwound the double-stranded DNA to 2 single strands. Unwinding is otherwise called as denaturation. So all of you tell me, what is the first step of PCR? The first step of PCR is denaturation, wherein the parent double-stranded DNA is unwound to form 2 single strands. For this unwinding, I have to break all these hydrogen bonds. Hydrogen bonds get broken at higher temperature. So denaturation is carried out at a high temperature of 94 or 95 degree. So all of you tell me, what is the temperature at which we denature the DNA? 94 or 95 degree. After denaturation, I am going to use a DNA polymerase which is going to elongate a strand. But for my polymerase to elongate a strand, my polymerase needs primers. So in the next step, I am going to add 2 primers. Can you see that? I'm going to add 2 primers. Both the primers go and anneal to the flanking sequences. What do I mean by flanking sequences? Terminal sequences of the desired fragment. So tell me, how many primers do you add? 2 primers. Those primers anneal where? They go and anneal only to the flanking sequences of the desired fragment. So this step is called as annealing step. Right? How should this annealing step temperature be? Should this annealing step temperature be high or should it be low? The annealing temperature should not be high. If the temperature is high, hydrogen bonds here will keep getting broken. But at the same time, it should not be too low. If the annealing temperature is too low, these primers go and anneal somewhere else. I want my primers only to go and anneal to the flanking sequences of my desired fragment. So the annealing temperature should be neither too high nor too low. It has to be optimal. It has to be just 5 degrees less than the melting temperature of my primers. Do you understand this? It has to be 5 degrees less than the melting temperature of my primers. For example, if the melting temperature of one primer here is 60, the other primer here is 62. One melting temperature is 60, the other melting temperature is 62. The average is 61. What is 5 degrees less than 61? 56. So in this case, annealing temperature will be 56. But it is variable. It varies based on the melting temperature of the primers. Are you clear? It is just 5 degrees less than the melting temperature of primer, but otherwise it is variable. Okay. So after annealing, my DNA polymerase is going to elongate new strands. And so the next step is called as elongation step. For this elongation, I need a thermostable DNA polymerase. What do I mean by thermostable DNA polymerase? The DNA polymerase has to be capable of withstanding cyclical rise of temperature to 95 degree. So I need a thermostable DNA polymerase. That is why I extracted DNA polymerase from an organism which lives in hot spring. If it can live in hot spring, it means all its proteins are thermostable. And that DNA polymerase is stack DNA polymerase. Why is it called a stack DNA polymerase? Because the organism is Thermus aquaticus. Because the organism is Thermus aquaticus, the DNA polymerase is stack DNA polymerase. The optimum temperature required for stack DNA polymerase to elongate a new strand is 72 degree. That is why elongation is carried out at 72 degrees. Are you clear? Yeah. So all of you tell me, what are the 3 steps of every cycle of PCR? The 3 steps are denaturation, D, annealing A, elongation E. Denaturation is carried out at 95 degree. Annealing is carried out at 5 degrees less than the melting temperature of primers. Elongation is carried out at 72 degrees. The DNA polymerase is stacked DNA polymerase. The instrument that I need is thermocycler. The instrument that is needed for this polymerase chain reaction is called as thermocycler because the instrument cycles between temperatures. First, it rises the temperature to 95. Then it reduces it to 5 degrees less than the melting temperature of primer. Then it increases it to 72. All that the machine does is it cycles between temperature. That is why the machine is called as thermocycler. Got it? Yeah. So now about cycles of PCR. This is one cycle. So at the end of one cycle, from one product, you get two products. From one template, you get two products. At the end of the second cycle, from 2, you get 4. At the end of third cycle, you get 8. So do you see that it is 2 to the power of n, where n is the number of cycle, 2 to the power of 2 is 4, 2 to the power of 3. So in every cycle, it gets doubled. So that at the end of 30 to 35 cycles, you get 2 to the power of 30 to 2 to the power of 35 products. In every cycle, it gets double. So that at the end of 30 to 35 cycles, you get 2 to the power of 30 to 2 to the power of 35 products. Okay. And this was asked recently in NEET PG 2024, right? What was the question? The question said, at the end of 25th cycle, they get n number of products. At which cycle they would have gotten half the number of products. Half the number of those products would have been obtained in the previous cycle. So 25th cycle, if you get n number of products, n by 2 would have been obtained in 24th cycle. Do you understand this? That's all. Such a simple concept it was. Okay. Very good. Yes. Another example for why image-based question is a blessing, right? Even if you know nothing about RFLP, you see the term RFLP here. Even if you know nothing about RFLP, my guarantee to you is you will be able to answer this question if you just apply your mind to it. Okay, so let's read the question. Let's see the image. Let's see if you are able to answer this. 3 individuals A, B, and C of a family of sickle cell anemia want to get their molecular diagnosis done with the provided RFLP. You know, RFLP is restriction fragment length polymorphism. Restriction fragment length polymorphism is a technique which uses an enzyme called as restriction enzyme. So what they've shown you here is RFLP data using an enzyme MST2. Okay. Choose the genotype of persons A, B, and C. Let's see what is seen in the image. They've shown you MST2 restriction sites around the beta globin gene. You know, sickle cell anemia is caused by a point mutation of beta globin gene. They've shown you the restriction sites of beta globin gene for MST2 by arrows. So beta globin gene has got 3 restriction sites. But they have told you this restriction site is lost in sickle cell anemia. Meaning, if a person has got sickle cell anemia mutation, this will not be cut. Yeah, if the person has got sickle cell anemia mutation, this will not be cut. It will come out as 1.4 kilo base pair. Do you get it? But if the person has got normal gene, then this will be cut. If it is cut, the length will be 1.2 kilo base pair. Do you all understand the facts that are given in the question? Let me erase all that I've written here. Okay. So the image shows you MST2 restriction sites. They've told you that this restriction site will be lost in the presence of sickle cell anemia. So if there is sickle cell anemia, this will not be cut. If it is not cut, the length will be 1.4 kilo base pair. If it's normal, it will be cut. If it's normal, the length will be 1.2 kilobase pair. Yeah. For codon position, I have browsed as many sites as possible. I have not been able to find out the exact evidence for the change in codon change. I still think it is 6th codon. Okay. So for those of you who are not able to see the image because I'm seated here. Okay, so this is the image. So what you see for person A. So, okay, can you see it now? Yeah. So what you see for person A is, for person A, this is 1.2 kilobase pair. Person A is 1.2 kilobase pair, which means it is cut. Right? If it is cut, it means normal. So person A is normal. Look at person C. Person C is 1.4. If it is 1.4, it means it has not been cut. Right? If it has not been cut, it means it is mutated. If it is mutated, person C is deceased. Look at person B. One allele is cut, the other allele is uncut. Cut is normal, uncut is mutated. So the person B has got heterozygosity of mutation. Person B is a carrier. Do you all understand this? Person B is a carrier. So who is person A? Person A is normal because both alleles are cut. Person B is a carrier. Person C is deceased. I hope it's clear. Yeah. So let me tell you a bit about RFLP. RFLP is restriction fragment length polymorphism, which uses restriction enzymes. And these restriction enzymes cut at specific sites. So RFLP can be used to detect known mutation sites. Do you understand this? RFLP can be used to detect known mutation sites, provided these mutation sites are restriction sites of an enzyme. Provided these mutation sites are restriction sites of an enzyme. Now, depending upon whether it is cut or uncut, you will be able to make a diagnosis. Okay. But what is step number 1 before RFLP? Before RFLP, you should get the fragment that you want. If you want beta globin gene fragment, first take the human chromosome. You subject the human chromosome to PCR using specific primers in such a way that you get the beta globin gene. You subject the human chromosome to PCR using specific primers in such a way that you get the beta globin gene. This beta globin gene length is 1.4 kilobase pair. This is where you have the 6th codon. Right? This is where you have the 6th codon. 6th codon is the restriction site of an enzyme, MST2. And you know MST2 cuts it if it's normal. If it cuts it, what will be the length of the fragment? The length of the fragment will be 1.2 kilobase pair. If it is not cut, the length will be 1.4. So then you run through electrophoresis, you see the length. If you see the length is 1.4, if the length is 1.4, it is not cut. If it is not cut, it is mutated. If the length is 1.2, it is cut. If it is cut, it is normal. If you see both 1.4 and 1.2, it is a carrier. Okay, so what are the steps to be followed for detecting a known mutation site? For detecting a known mutation site, first you extract DNA, you subject the DNA to PCR, you get the fragment that you want, and after you get the fragment, to find out whether it is mutated or unmutated, you subject it to RFLP, you run it through electrophoresis, and then you make a diagnosis. Are you clear? So, yeah. Can you all try answering this question? Two individuals A and B diagnosed with chronic myeloid leukemia are investigated for the presence of Philadelphia translocation by a cytogenetic technique. The results are provided here. Name the technique and provide the diagnosis. You know the technique, right? What is the technique? It is FISH. And tell me person A and person B. In person A, do you see green color and red color coming from different chromosomes? Whereas in person B, let me magnify it for you. In person B, do you see green and red coming from the same chromosome? Right? So what is Philadelphia chromosome? Philadelphia chromosome is BCR-ABL translocation. I hope you know that. Right? Philadelphia chromosome is BCR-ABL translocation. You know BCR actually is present in chromosome 22. ABL is actually present in chromosome 9. Okay. So what is FISH? FISH is fluorescent in situ hybridization. Then you use specific fluorescently labeled probes. So to find out BCR-ABL translocation, I should use two probes. One for BCR sequences, the other one for ABL sequences. Both will be differentially labeled. I am going to label the BCR sequences with red label, ABL sequences with green label. And I am going to add it to metaphase arrest chromosome of a cell, nucleated cell. What is normal? Normal is red signal and green signal should come from two different chromosomes. Right? Red and green should come from different chromosomes, which means red is somewhere, green is somewhere. 22 is separate, 9 is separate. So here in person A, all these are coming from different chromosomes. Do you see anywhere red and green coming close by? No. So there is no translocation. So person A is Philadelphia chromosome negative. Right. What about person B? In person B, here you see BCR and ABL coming from the same chromosome. It means person B is Philadelphia chromosome positive. Is it a good news or bad news for person B? Yeah, person B, it's a good news, I would say. If Philadelphia chromosome is positive, you can put them on tyrosine kinase inhibitor. You have a targeted therapy for which the person is going to respond quickly. Right? So what is the technique? The technique is FISH. Yes, C and D are the same choices. I'm sorry. So it is a FISH technique and person A is BCR-ABL negative. Person B is BCR-ABL positive. Yes, targeted treatment. Okay. So let me tell you a bit about FISH before we end the session today. What is FISH? FISH is a cytogenetic technique which is used to find out chromosomal aberrations. It can be used to detect copy number variations. It can be used to detect translocations. It can be used to detect microdeletion. Give me a second. So it can also be used to detect microdeletion, and all these are possible only because you are able to choose specific fluorescently labeled probes, right? Suppose you are trying to detect copy number variation like trisomy 21, right? Trisomy 21. You choose a fluorescently labeled probe which is complementary to chromosome 21 sequences. You label it with a green fluorescent dye. You add it to metaphase arrest chromosome of a cell. And if you see 3 signals coming from a nucleated cell, it means it is trisomy 21. Okay, so copy number variations can be detected. And yes, structural alterations can also be detected, like how I showed you here. It can be used to detect BCR ABL translocation, when you know that it has moved from one place to another. It can also be used to detect micro deletions like Prader-Willi syndrome and Angelman syndrome, wherein again you can synthesize fluorescently labeled probe complementary to those sequences which are suspected to have undergone micro deletion. You label it with a green fluorescent dye, add it to metaphase arrest chromosome. If you don't see a signal, then that segment has undergone micro deletion. So fish can be used to find out all these variations. What you cannot use fish for? You cannot use fish to detect deletions at the nucleotide level, right? You cannot use fish to detect point mutations. You cannot use it as a molecular diagnostic technique when you're trying to detect nucleotide base changes or nucleotide base deletion or nucleotide base insertion. At the very small level, it cannot be used. Fish can be used only for chromosomal aberrations. Are you clear? So the right answer here is, it is fish. A is negative, B is positive. Okay. So that's all for today. I hope you enjoyed this session. The PDF will be shared, and I want you to watch this session as many times as possible so that you get a clear understanding of all the concepts that we have discussed today, right? So all the topics which I was not able to cover in LRR session have been covered, and those topics that were covered in LRR are also covered here. So before you go for your exam, do watch LRR session, do watch image-based question, and do quickly watch rapid revision videos. Work out as many questions as possible. Stay positive, right? You will be able to achieve this. Thank you. Good night.